Good morning, everyone. Kindly make sure that your audios are muted. Welcome to the second session of Exam Tips 2021, a state-level review program for the third-year undergraduate students focusing on oral pathology and microbiology, organized by Annoor Dental College, Muvatupuzha. A word of prayer and gratitude to God Almighty for granting us health and safety during these tough times of pandemic. A moment of silence to invoke the blessings of God Almighty. Annoor Dental College and Hospital, Muvatupuzha, is the 22nd among private dental colleges in India, as per the survey conducted by the Week magazine, and is also recognized as the College of the Year 2019 by the Higher Education Review magazine. We take pride to announce our recent achievement of being accredited a B++ grade by NAC, the National Assessment and Accreditation Council, the highest grade for a standalone dental institution. Our students are recipients of various funded research projects under the coveted ICMR, Kerala State Council of Science and Technology, and Tata Trust Scholarship. Here, we present before you our institution with utmost pride and dignity.
History has proven that those who dare to imagine the impossible are the ones who break all the human limitations.
यस्यां समुद्र उत सिन्धुरावो यस्यामन्नं पृष्ठयः सम्बभूव यस्यामिदं जिन्मति प्राणदेय सा नो भूमिः पूर्वमेव दधातु।
Thank you all for watching. Exam Tips 2021, organized by Annoor Dental College and Hospital, take pride to welcome all the esteemed speakers for the day. Professor Dr. Sudha S., Head of the Department, Government Dental College, Thrissur. Professor Dr. Rakesh S., Head of the Department, Amrita School of Dentistry. Professor Dr. Jubin Thomas, Head of the Department, Malabar Dental College. Dr. Priya Thomas, Reader, Annoor Dental College and Hospital, Muvatupuzha. We welcome you, ma'ams. We welcome you, sirs. Participants, kindly note, any queries and doubts regarding the topics should be posted in the chat box below. We shall be attending and discussing the same after the session. Moving on, our first session is on the topic epithelial pathology by an eminent speaker, Dr. Sudha S. Professor Dr. Sudha S. is the Vice Principal and Head of the Department, Oral and Maxillofacial Pathology, Government Dental College, Thrissur. She completed her BDS and MDS from the Government Dental College, Calicut in 2000, and she holds to her credits many awards and recognitions, including the Kerala State Government Best Doctor Award in 2016, the Best Academician Award by the Global Society of Health and Education, and Women Achiever Award. She is the chairperson of Pain and Palliative Care Society, Calicut, and the immediate past president of the Kerala State Oral and Maxillofacial Pathology. Apart from being the member of KUHS Board of Studies, she has got various scientific publications in state, national, and international levels. We are privileged to have the first speaker of the day, Professor Dr. Sudha S. Over to you, ma'am. Ma'am, could you please unmute yourself?
Good morning, all. Am I audible?
Yes, ma'am, you're audible. Good morning, ma'am.
Okay. Thank you for the kind introduction. May I know your name, please?
Myself, Dr. Veena, ma'am.
Dr. Rina, thank you so much for the kind introduction. And thank you, Dr. Deepu George and Dr. Priya Thomas and the entire team of pathology, Annoor Dental College, for giving me this opportunity. And I would like to congratulate Principal Dr. Dr. Jiju George and the management for supporting the students, especially during this COVID-19 pandemic. Okay. So let us see what is the importance of oral pathology in dentistry. Okay. Oral health has a grand impact on your physical, mental, psychological, and social well-being. So acquiring knowledge and thorough understanding of diseases and imparting the same and sharpen the professional skills in the subject to help them to emerge in future. As malignancies and other diseases are increasing, oral pathologists can play a significant role in society in terms of early detection and timely management. And awareness about risk factors also plays a major role in improved cancer survival also. Okay. With this, let me move on to my topic, that is epithelial pathology. So you should have some kind of understanding about the terminologies before going deep into the subject. It is atrophy, hypertrophy, hyperplasia, metaplasia, and prosoplasia and heteroplasia. So, you have studied and learned about atrophy, hypertrophy, hyperplasia, and metaplasia. You know what is metaplasia? Transformation of one type of cells to another. What is prosoplasia? Prosoplasia is differentiation at a higher level. For example, mucous prosoplasia in odontogenic cysts and retroplasia is to a lower level. For example, columnar cells, lung columnar cells to virally included cells. This may appear as viral inclusion cells. No? Then what is neoplasm? You must have studied this in the second year and just refresh this. Okay. And will is defined. It's an abnormal mass of tissue, the growth of which exceeds that of normal tissues and persists in the same excessive manner even after the cessation of stimuli, which evoke the response. What is hematoma? Hematoma is a benign focal malformation that resembles a neoplasm, the tissue, which is native to that tissue. Okay. And what is choristoma? That's a rare benign tumor consisting microscopically of normal tissue that is derived from germ cell layers, which is foreign to that body site. For example, cartilaginous and osseous tissues in the lung and the tongue and buccal mucosa. Okay, and palate. And what is a teratoma? It's a true neoplasm which is made up of different types of tissue which may not belong to the area in which it occurs. For example, ovarian teratoma, which contains teeth, hair, etc. And what are the differences between benign and malignant tumors? you would have been learned this in the second year itself. Okay, just go through this. The size of tumor usually small and benign, malignant usually large, rate of growth slow for benign, and it's malignant. It's very fast. Pain is absent for malignant. Benign, and it is mostly present. And malignant tumors, hemorrhage is rare for benign. It is very common. For malignant neoplasm, ulceration is absent for benign, and this is present. Malignant tumors, paresthesia does not occur for benign, and it is present, commonly occurs for malignant tumors. Okay, fixation to the underlying tissue is absent, often fixed to the neighboring structures and malignant tumors. And about cell multiplication rate, it is slow for benign, and malignant, it is very fast. And cell maturation is normal benign, and in malignant maturation, immature cells, you can see. Okay. Cell morphology is not altered in benign. However, for malignant, is altered or lost. And tissue architecture is maintained for benign tumors, and for malignant, is mostly destroyed. And superadded infection is absent for benign, and it is very common for malignant. Prognosis is good for benign tumors, and it is bad for malignant tumors. That's all about the differences between benign and malignant tumors. We come to the tumors of epithelial origin. So tumors of epithelial origin is broadly into benign and malignant. Okay? So what are the tumors derived from benign tumors derived from epithelium? The first is papilloma, then keratoacanthoma. And malignant tumors are squamous cell carcinoma, basal cell carcinoma, verrucous carcinoma, and malignant melanoma. Once again, I repeat, benign tumors which are derived from epithelium. One is papilloma, then keratoacanthoma. That is otherwise known as self-healing carcinoma or self-healing ulcer. Malignant tumors which are derived from epithelium are squamous cell carcinoma. It's the most common malignant tumor affecting oral cavity, then basal cell carcinoma, verrucous carcinoma, and malignant melanoma. Come to what is papilloma? It's a generic disease process representing localized epithelial proliferation. They typically have a roughened or exophytic growth. This is usually associated with HPV, human papilloma virus infection. Oral papillomas include squamous papilloma, verruca vulgaris, and condyloma acuminatum. What is squamous papilloma? Just a few words studying squamous papilloma. It's a benign proliferation of stratified squamous epithelium, and the surface appears papillary or verruciform. Okay. This is characterized by proliferation of stratified squamous epithelium in a finger-like or verruciform pattern, and the central core of vascular connective tissue is the central core of vascular connective tissue. And it is induced by HPV virus, usually type 11 and 6 and 11. And just a few words about what is HPV virus. It's a double-stranded DNA virus of Papilloma family. And buccal epithelial cells of almost 81% of normal adults have at least one type of HPV. These higher levels are present in diseases and lower in normal cells. The exact mode of transmission is not known. However, person-to-person spread by sexual and non-sexual routes transmission has been proposed as etiology. Coming to the clinical features, it is equally distributed in males and females. Okay, can occur at any age. However, between more commonly seen in between 30 and 50 years of age, and it may develop at any intraoral site. Tongue is the most common site, then lips, buccal mucosa, and soft palate. And about the clinical presentation, it appears as soft, painless, pedunculated, exophytic, slow growing, soft, painless, pedunculated, exophytic nodule with numerous finger-like projections on its surface. And this is termed as cauliflower or verruciform-like. Usually appear as white or red, depending on the characterization of normal color. And papillomas are generally solitary and enlarged to a maximum size of about 0.5 centimeter. This is the clinical presentation. You can see a nodule. Here at the lateral border of tongue. See the palate. You can see a papilliferous growth at the palate and the lip. Is it clear? Is it clear to you? Hello?
Ma'am, it's clear, ma'am. It's
Okay,
fine.
okay. Well, so coming to the histopathologic features, proliferation of keratinized stratified squamous epithelium in the form of rounded finger-like projections, and each epithelium, listen, rounded finger-like projection, and each epithelial projection has got a central fibrovascular connective tissue core. And the surface keratin layer is thickened in addition with a whiter color, which gives white color. Okay. Features of mild atypia like basilar hyperplasia and a few mitotic figures may be seen in the epithelium. And some virally altered epithelial cells. This may appear as dark cells with a small dark pycnotic nuclei and a spinous layer. They are called the coilocytes. Okay. So virus altered epithelial cells may appear as clear cells with a small dark pycnotic nuclei in the spinous layer. They are called the coilocytes. That can be asked as a short question. Okay. And the gross and microscopic pathology of, see, the finger-like projections of proliferating surface epithelium and the central connective tissue, fibrovascular connective tissue core. Okay. It's a peduncle lesion. See attachment. And these are coilocytes. Then, verruca vulgaris. What is verruca vulgaris? This is a common word usually associated with the herpes types, that is 2, 4, 6, and 40. And usually it is seen in the skin, which is very uncommon in the oral mucosa. Usually occurs in the, if it occurs, usually occurs in the anterior aspect of the oral cavity due to autoinoculation. And oral lesions are always white in color, indicating heavy keratinization, and it is a very contagious lesion. Histopathologically, the epithelial projections are pointed and narrow. Elongated retroridges converge towards the center, giving a cupping effect. And keratin layer is usually very thick, and stratum granulomatosis is prominent, and granulosum is prominent with eosinophilic intranuclear inclusions, and a significant number of coilocytes are seen. So this is the histopathologic photomicrograph of verruca vulgaris. And next is condyloma acuminatum. This is also very rare in the oral cavity, where venereal and were typically associated with the HPV 6, 11, 16, 18, 53, and 54. Oncogenic HPV 16 and 18 are common in the age of anogenital lesions, but it is less common in the oral cavity. And typically it's seen in the anterior aspect of the mouth and on the lingual frenula. And this is a sexually transmitted disease with the lesions developing at the site of sexual contact or trauma. And when it is seen in children, it is indicative of child abuse. When condyloma acuminatum is seen in children, it is indicative of child abuse. Okay. And incubation period is about 1 to 3 months, and the lesion is highly contagious. And it may be multiple and typically non-keratinized and thus the same color as surrounding tissue. Histologically shows broader papillomas than the squamous papilloma, and coilocytes are prominent in the cervical lesions. And what is the management of papilloma? Surgical excision, including the base of the lesion. Recurrence is very unlikely, and no reports of malignant transformation so far. Non-surgical modes of excision like laser ablation, cryotherapy, topical agents like podophylletoin are also used. And anogenital lesion. However, these anogenital lesions are at high risk for malignant transformation. So the differential diagnosis summary is squamous papilloma, HPV type 6 and 11. Squamous papilloma, HPV type 6 and 11. And it is non-contagious and low infectivity and low virulence. Usually affects mucosal region, oral mucosal region. And verruca vulgaris, this type 2, 4, 6, and 40. It is really contagious, it affects skin. And condyloma acuminatum, HPV types 6, 11, 16, 18, 53, and 54. It is highly contagious and sexually transmitted disease, usually affects energetic mucosal region. Okay. Then what is keratoacanthoma? Okay, another benign epithelial neoplasm is keratoacanthoma, otherwise known as self-healing carcinoma or self-healing cancer. Clinically and histopathologically, it resembles squamous cell carcinoma. So why it's called self-healing carcinoma? Clinically and histopathologically, it resembles squamous cell carcinoma. And it originates in the pilosebaceous gland. It's a relatively common low-grade malignancy that originates in the pilosebaceous glands. Okay. Coming to the etiology of keratoacanthoma or self-healing ulcer. First is exposure to sunlight, exposure to cold tar, trauma, HPV 9, 11, 13, 16, 18, 24, 25, 33, 35, and 57. Okay, genetic factors are also involved and can occur in immunocompromised state also. And coming to the clinical features of keratoacanthoma or self-healing carcinoma. Reported in all age groups, but it occurs twice in men as women, and it is less common in darker individuals, mostly occurs in sun-exposed area, face, neck, dorsum of upper extremities, common sites, and 8.1% of cases occurred on the lips. It is seldom seen over 1 to 1.5 centimeter in diameter. Clinical features can be solitude, firm, round papules. See? Solitary firm round papules which rapidly progress to dome-shaped nodules with a central ulceration of or keratin plug which projects like a horn. Okay. Clinical course is very typical and it starts as a small firm nodule which grows in size over 4 to 8 weeks, and it remains static for next 4 to 8 weeks. Then it undergoes spontaneous regression over next 4 to 8 weeks by expulsion of this keratin and resorption of the mass. Okay. Overall duration of the lesion is as long as 2 years. The rapid growth of which is seen leads to suspicion of malignancy. Okay. So the differential diagnosis for keratoacanthoma or self-healing cancer is actinic keratosis, molluscum contagiosum, squamous cell carcinoma, and tuberous carcinoma. Coming to the histopathology, hypoplastic squamous epithelium, which grows into the underlying connective tissue, and the epithelium shows hyperparakeratosis or hyperorthokeratosis, and you see central plugging of keratin. And at the deep epithelial margin, the islands of epithelium appears to be inverting the connective tissue. This leads to the suspicion of squamous cell carcinoma. So this is the histopathology of self-healing carcinoma or keratoacanthoma. Central crater is filled with the keratin. See? Clinical features and histology. Why this is called self-healing cancer? Why? Because clinical features and histopathologic features are suggestive of malignancy. However, it heals on its own without any treatment. Thus, the term self-healing cancer. Okay. These are the benign tumors which are derived from epithelium, squamous epithelium. So what about the treatment of the lesion? Lesion is usually treated by surgical excision. When spontaneous regression occurs, residual scar may be present. And prognosis is excellent following excision. And patient with a history of keratoacanthoma should be followed for the development of new primary skin cancers. Patients with a history of keratoacanthoma should be followed for the development of new primary skin cancers. So these are the benign tumors which are derived from epithelium. Okay. Coming to the potentially malignant disorders under this, in your curriculum, it is given a separate pre-malignant lesion as pre-malignant condition. So the definition for pre-malignant lesion is a morphologically altered tissue in which cancer is more likely to occur than its apparently normal counterpart. It is given by WHO workshop in 1978. Then definition for pre-malignant condition is a generalized state associated with a significantly increased risk for cancer, generalized state associated with increased risk of cancer. Okay, then come to the pre-malignant. What are the pre-malignant lesions? Just that leukoplakia. First is leukoplakia, then erythroplakia, leukokeratosis, nicotinopalia, candidiasis, and carcinoma in situ. Once again, pre-malignant lesions are leukoplakia, erythroplakia, leukokeratosis, nicotinopalia, candidiasis, and carcinoma in situ. And pre-malignant conditions: oral submucous fibrosis, oral lichen planus, actinic keratosis, syphilis, discoid lupus erythematosus, and sideroplanic dysphagia. And about potentially malignant disorders. So it was recommended in WHO workshop of 2005 to abandon the distinction between precancerous lesion and conditions and use the term potentially malignant disorders, instead incorporating both the terminologies. However, in your curriculum, it is given under separate. Okay. So what is dysplasia? Epithelial dysplasia. For me, epithelial dysplasia can be defined as morphological and biochemical alteration of tissue at the genetic and epigenetic level. So epithelial dysplasia can be defined as morphological and biochemical alteration of tissue at the genetic and epigenetic level, and it is characteristically associated with protracted chronic irritation or inflammation. What are the histomorphological changes of dysplasia? So it can broadly, easy understanding, can broadly into architectural changes and cellular changes. So the dysplasia can be, displaced features can be classified broadly into architectural changes and cellular changes. What are the architectural changes? We'll see. In dysplasia, drop-shaped retiriges, loss of basal cell polarity, basilar hyperplasia, loss of stratification, and hyperkeratosis. Once again, architectural changes are drop-shaped retiriges, loss of basal cell polarity, basilar hyperplasia, loss of stratification, and hyperkeratosis. Coming to the cellular changes, cellular and nuclear hyperchromatism, increased nuclear cytoplasm ratio. And why there is cellular and nuclear hyperchromatism? Nuclear hyperchromatism is there. Why? Because of increased nucleic acid content. And next is increased nuclear cytoplasm ratio. So what is a normal nuclear cytoplasm ratio? That is about 1:4 to 1:6. In dysplasia, become 1:1. Enlarged nucleoli, it's due to demand of the, it's a prominent structure which is seen in nucleus during the interphase of cell division. It's for RNA synthesis, transcription, and processing. So during dysplasia or carcinomatous change, it will become highly secreted and increased and abnormal mitosis activity. Again, mitosis is a normal procedure. However, in dysplasia, you see increased mitosis and abnormal mitosis. What do you understand by this increase and abnormal mitosis? I told you that mitosis is a normal procedure. Usually, mitotic figures are seen at the basal and the parabasal region. That's why it's called stratum germinativum. Remember? Okay. And in dysplasia, you see mitotic figures above these layers, and usually, and abnormal mitosis means normally the mitotic figures are phase, metaphase, anaphase, and telophase. In dysplasia, you get tripod or tetrapod mitosis. And last one is individual cell keratinization. Again, you all know keratinization is a normal procedure. Then what is happening in in dysplasia? Usually, normally keratinization occurs at the superficial layer. In dysplasia, it is below the superficial layer. That is due to increased cellular turnover rate, malignancy. Okay. See, loss of polarity of the basal layer. You can see loss of polarity of the basal layer. You know what do you mean by loss of polarity of the basal layer? Normally, the basal cells are arranged at right angle to the basement membrane. In dysplasia, you see the arrangement of cells are different. And basilar hyperplasia, see basilar number of basal layer is increased. increased nuclear cytoplasm ratio. Normal nuclear cytoplasm ratio is 1:4 to 1:6. It became 1:1. And nuclear hyperchromatism. See, this is the architectural feature here. You can see drop-shaped retiridges and hyperparakernization. And irregular epithelial stratification, you see. Irregular epithelial stratification. Increase mitotic activity. See, more towards the superficial. Is the individual cell keratinization. Individual cell keratinization and keratin pearl formations. These are the clinical features. This is normal mucosa, helicobacteric patch, ulcerate lesion, became carcinoma. Okay. So again, this is the red diagram representation, normal mucosa, then hyperplasia. What is hyperplasia? Hyperplasia is increase in the number of cells. So dysplasia, once again I repeat, morphological and biochemical alteration of tissue at the genetic and epigenetic level. You can see disrupted basement membrane here. The tumor cells are infiltrating just into the connective tissue. Okay. Then what is leukoplakia? Leukoplakia is a clinical term. Okay. But it originates, Greek word from leukos means white and plakia means a patch or raised lesion. Okay. A white patch or plaque that cannot be characterized clinically or pathologically as any other disease. This is the definition for leukoplakia. It's a white patch or plaque that cannot be characterized or clinically or pathologically as any other disease. This is the definition for leukoplakia. Then how it is classified? It's based on the clinical type. Clinical presentation, it is classified as homogeneous leukoplakia, and homogeneous leukoplakia, it is smooth, furrowed, or ulcerative, and non-homogeneous leukoplakia. So this is homogeneous leukoplakia, furrowed, and ulcerative leukoplakia. And non-homogeneous leukoplakia usually present as ulcerative, verrucous, suspected, or erythroleukoplakia. Based on etiology, is tobacco associated, idiopathic. Based on etiology, it is classified as tobacco associated and idiopathic without any etiology. And based on extent, it is localized or diffuse involvement. Etiology of leukoplakia is smoking, alcohol, candida albicans, and role of viral antigens, especially HPV 16 and 18 have been. Clinical presentation usually, the demographer is got a male predilection, mostly occurs in 4th to 7th decade of life. Actually may present as solitary or multiple white patches. May vary from non-palpable, faintly translucent white area to thick fissured papillomatous or indurated lesion. And 70% of it is seen in buccal mucosa, commissural areas, followed by lower lip and floor of mouth, palate, and then gingiva. And what are the histopathological features? Leukoplakia is a clinical term, and it is recommended that the histological report or histopathological report should always include a statement on the presence or absence of epithelial dysplasia. And it ranges from mild to severe and carcinoma in situ. This is normal appearing mucosa in HNG. See mild mucosa, see basilar hyperplasia and hyperparakernization and mild dysplastic features. Okay. You can see that only about 1/3 of basal 1/3 is affected. Okay. Here you can see basilar hyperplasia, more hyperchromatism and increased nuclear cytoplasm ratio. Almost 2/3 of the epithelium is affected. That usually is moderate dysplasia. And in severe epithelial dysplasia, see more number of dysplastic features, abnormal mitosis, hyperchromatism, increased nucleocytoplasm ratio, hyperkeratosis, almost 3/4 of the epithelium is affected. Then you can give it as severe dysplasia. Then about the clinical staging. Clinical staging system for oral leukoplakia on the lines of TNM staging was recommended by WHO in 2005, taking the size L and histopathological features P of the lesion into consideration. And LX, no size not specified, L1, single or multiple lesions together less than 2 centimeter, 2 single or multiple lesions together between 2 and 4 centimeter, and L3, single or multiple lesions together between more than 4 centimeter. And P, epithelial dysplasia not specified, P0, no epithelial dysplasia, P1, mild to moderate epithelial dysplasia, P2, severe epithelial dysplasia, and stage 1 means leukoplakia means L1, P0, stage 2, L2, P0, stage 3, L3, P0 or L1 or L2, P1, stage 4, L3, P1 or LX, P2. And about the malignant potential, for leukoplakia, malignant potential, it has got a high malignant potential, right? That's about 5 to 18%. And coming to the factors which are associated with a greater risk for malignant changes, non-homogeneous leukoplakia, a proliferative verrucous appearance or multifocal appearance leukoplakia, that is idiopathic, and tongue and floor of mouth. If the lesion in the tongue and floor of mouth is a high risk site for malignant transformation, and presence of multiple lesions and history of no smoking cigarettes. And coming to the differential diagnosis of leukoplakia, it's white sponge nevus, acute white sponge nevus is familiar, then acute pseudomembranous candidiasis is a scrapable lesion, leukodema, white stretching, this may appear like planus, black type, usually occurs bilateral with became striate. Okay. And coming to the treatment and prognosis, this first step in the treatment is to arrive at a definite histopathological diagnosis. Therefore, a biopsy is mandatory and will guide the course of treatment. A tissue to be obtained for biopsy should be taken from the clinically more severe or representative areas of injury. And multiple biopsies of large or multiple lesions may be required. A non-surgical treatment, chemoprevention, ascorbic acid, that is vitamin C, tocopherol, alpha-tocopherol, vitamin E, retinoic acid, vitamin A, and vitamin A derivatives, isotretinoin and 13-cis-retinoic acid is about 28,500 international unit per day, and beta-carotene about 150,000 international unit of beta-carotene twice per week for 6 months. And bleomycin topical can also be used as a topical agent. However, you must use a probiotic along with this and make our gut strong. Okay. Surgical management includes scalp excisional stripping, electrocautery, cryotherapy, carbon dioxide laser therapy. And coming to the proliferative verrucous leukoplakia or PVL. And this is described by Hansen et al. In 1985. It's an aggressive form of oral idiopathic leukoplakia, which has got a strong potential for malignant transformation. And histopathological spectrum or verrucous hyperplasia and varying degrees of dysplasia. And 3 forms of squamous cell carcinoma are verrucous, conventional, and papillary squamous cell carcinoma. And what is intraepithelial carcinoma or carcinoma in situ? Previously, it was under epithelial dysplasia. Now it is. However, intraepithelial carcinoma or carcinoma in situ is a more severe form of epithelial dysplasia. There is top to bottom change. The striking feature: dysplastic epithelial cells do not invade into the connective tissue. The dysplasia, let's say, from base layer to the superficial layer, but there is no infiltration into the connective tissue. It is usually seen in elderly people with a male predilection. Usually present as white plaques or ulcerated and reddened areas, and common sites of involvement are floor of mouth, tongue, lips. It's got combined features of leukoplakia and erythroplakia. And if it occurs in the skin, it's called Bowen's disease and also occur on the mucous membrane. In the skin, it is called a Bowen's disease. There is no accepted treatment for this in skin. However, surgical excision, irradiation, and cauterization happened. And what is erythroplakia? Also known as erythroplasia of Coit. And this was first described by Coit in 1911 as a lesion occurring on the glans penis. And WHO definition, a very red patch that cannot be characterized clinically or pathologically as any other definable lesion. Incidence, it is more common in males and occurs more frequently in the 6th and 7th decade of life. Coming to the clinical features, it often red or velvety appearing lesions and well-defined patches. And most commonly present on the floor of mouth, retromolar trigone area, lateral border of tongue, symptoms usually asymptomatic and is usually smooth or nodular appearance. And homogeneous form, which appear as bright red, soft, velvety lesion with straight or scalloped, well-demarcated margins, often quite extensive in size, commonly found on the buccal mucosa and sometimes with soft palate, rarely on the tongue and floor of mouth. Okay. Speckled leukoplakia or erythroplakia, which is soft red lesion that are slightly elevated with an irregular outline and a granular or fine nodular surface speckled with tiny white patches. What are the differential diagnoses for this? It is erythematous, atrophic or erythematous candidiasis, Kaposi sarcoma, ecchymosis, contact stomatitis, vascular malformations, squamous cell carcinoma, geographic tongue, and erythema multiforme. And coming to the histopathologic features, epithelium shows lack of keratin. That is why this lesion appears red in color and is often atrophic. And the connective tissue often demonstrates chronic inflammation. Then what about the management of these lesions? Biopsy. Biopsy is the gold standard for all diagnosis of lesions. Biopsy should be performed, treatment guided by histopathological diagnosis. Recurrence and multifocality is common and follow-up is necessary. Coming to nicotinous stomatitis or smoker's palate. It is seen among conventional smokers. It consists of grayish white palate with small nodular excrescences having small central spots corresponding to the inflamed orifice of the minor salivary glands. It exhibits neither great variability nor malignant transformation. See this is the clinical appearance of nicotinous palate or smoker's palate. The palatal changes usually associated with the reverse smoking on the other hand are multimorphologic or precancerous. And the palatal changes include keratosis, excrescences, patches, red areas, ulcerated or non-pigmented areas. And histological features include hyperorthokeratosis, epithelial dysplasia, inflammatory cells in the connective tissue, sometimes melanin deposits are noted in the lamina propria. And coming to the pre-malignant condition, first is oral submucous fibrosis. This can be asked as a question, oral submucous fibrosis. This is the definition of oral submucous fibrosis. It is an insidious chronic disease affecting any part of oral cavity and sometimes the pharynx, although occasionally preceded by or associated with vesicle formation, and it is always associated with the juxtaepithelial inflammatory reaction followed by fibroelastic changes of the lamina propria with epithelial atrophy leading to stiffness of the oral mucosa causing trismus and inability to eat. It is given in the textbooks like you must read the textbook also. Okay, this definition by J.J. Pinpo consultant in 1966. First, Shows was described the descriptive term atropia idiopathica mucosa oris. Later, Joshi in 1953 redesignated the condition as oral submucous fibrosis. Coming to the etiology of oral submucous fibrosis, exact etiology of it is not unknown. The predisposing factors are chronic irritation of aconite, tobacco, chilies, and lime, and defective iron metabolism, bacterial infection, collagen disorder, immunological disorders, and genetic disorders. Okay, so what is the role of aracanite and OSR? This aracanite contains aracholine or arachidine. This is responsible for fibroblast proliferation and this may stimulate collagen synthesis. And it also contains tannin and catechin, makes collagen fibers resistant to collagenase. It is how the oral submucous fibrosis of this details. It is given in the chapter 5, page number, I think 152. Okay, please go through that. And chronic irritation, pathogenesis of oral submucous fibrosis, like the continuous action of mild irritants like chilies also. Chilies contain capsaicin, which is an extreme effect from capsaicin, is also important irritant action. And initial symptoms of oral submucous fibrosis are first burning sensation on eating spicy food, blisters on the palate, ulceration or recurrent stomatitis, excessive salivation, defective gustatory sensation, sometimes dryness of mouth. These are the initial symptoms. So initial symptoms of oral submucous fibrosis: burning sensation on eating spicy food, blisters on the palate, ulceration or recurrent stomatitis, excessive salivation, defective gustatory sensation, and dryness of mouth. In the later stages, difficulty in opening mouth, inability to whistle, inability to whistle and blow, difficulty in swallowing, referred pain to the ear, changes in tone of voice to vocal cord involvement because of the vocal cord involvement, and sometimes deafness due to occlusion of eustachian tubes. Common site involvement of buccal mucosa, facial pillars, soft palate, lips, hard palate, etc. And the fibrous bands in the buccal mucosa run in a most vertical direction, sometimes so marked that the cheeks are almost immovable. And in the soft palate, the fibrous bands radiate from the pterygomandibular raphe or the facial pillars and have a scar-like appearance. And if it involves the uvula, it shrinks and appears as small fibrous bud. See? The facial pillars become thick, short, and extremely hard. The tonsil may be pressed between the fibrous pillars. Lips are often affected, and when palpation, a circular band, circumoral band, can be felt around the entire lip mucosa. When gingiva is affected, it is fibrotic, blanched, and devoid of its normal stippling. See, you can see pale, bald tongue, depapillation of tongue. See, trismus. Trismus means nothing but that is difficulty in normal mouth opening. What is a normal mouth opening? That is about 44 to 55 millimeter. Okay. What are the clinical stages? There are 3 stages based on physical finding or clinical findings. Stage 1 is stomatitis, includes erythematous mucosa, vesicles, mucosal ulcers, melanotic mucosal pigmentation, and mucosal petechiae. Stage 1 stomatitis includes erythematous mucosa, vesicles, mucosal ulcers, melanotic mucosal pigmentation, and mucosal petechiae. And stage 2, fibrosis occurs in ruptured vesicles and ulcers when they heal. This is the hallmark of the stage. Okay, stage 3 is the sequelae of oral submucous fibrosis. Leukoplakia is found in more than 25% of individuals with oral submucous fibrosis, and speech and hearing deficits may occur because of involvement of the tongue and the eustachian tube. The 3 stages of clinical stages. No? Then histologic findings: atrophic epithelium, loss of retipex, epithelial atypia may be sometimes observed, and hyalinization and homogenization of the collagen bundles, obliteration of the blood vessels, and fibroblasts decreased. See, you can see atrophied epithelium, obliteration of the blood vessels. Obliteration means narrowing of blood vessels, and see bundles of collagen fibers in this. See, atrophied epithelium, obliteration of the blood vessels and bundles of collagen fibers. And histological grading of oral squamous cell carcinoma. It is graded as group 1, that is very early stage. You get fine fibrillar collagen network. Fibrillar collagen network. Marked edema of the connective tissue. In epithelium, in sometimes there is hyperplastic or normal looking epithelium with the high keratinization. And you will get acute inflammatory cells during the initial stage or very early stage histopathology or under microscope. In group 2 or early lesion, you'll get juxtaepithelial hyalinization. Juxtaepithelial hyalinization with collagen bundles, thick separate bundles, blood vessels somewhat dilated during the second stage. Okay, mainly here also have acute inflammatory cells and occasional chronic inflammatory cells. This is a flattening of the epithelial layers in varying degree of keratinization you can see. Okay, so in group 2 also you get atrophied epithelium, dilated blood vessels, hyalinization of the collagen, and the inflammatory component consists of acute inflammatory cells and few chronic inflammatory cells. In group 3 or moderately advanced stage juxtaepithelial hyalinization, you get faintly discernible collagen bundles which are separated by very slight or residual edema. Then muscle fibers usually interspersed within collagen fibers reveal the beginning of degeneration and irregularities or striae. And blood vessels are constricted and mature fibrocytes with a scanty cytoplasm and spindle-shaped nuclei. And inflammatory cells, mainly lymphocytes and plasma cells, are seen. They are chronic inflammatory cells. In group 1 and 2, acute inflammatory cells, whereas in group 3, chronic inflammatory cells. And then epithelium shows markedly atrophic with the total loss of retipex. This is group 4 of advanced stage. Collagen is hyalinized as a smooth sheet, eliminating all evidence of individual bundles. Individual collagen bundles. See? In extensive fibrosis, they obliterate the mucosal blood vessels. And fibroblasts markedly absent within the hyalinized zones. And extensive degeneration of muscle fibers, and total loss of retipex with a mild to moderate atypia. And how to manage a case of oral submucous fibrosis? Various modalities of treatment have been tried. Restriction of habits of behavioral therapy, non-surgical therapy, and surgical therapy, and oral physiotherapy. Then non-surgical therapy include antioxidants, intralesional injections of hyaluronidase, hydrocortisone, use of placentrix 2 ml solution at intervals of 3 days, topical application of 4% acetic acid 3 times daily, and fluorouracil can also, 5-fluorouracil can also be used. And systemic administration of immunomodulators like levamisole 150 mg for 3 weeks orally, and dapsone 75 mg on orally for 90 days orally can be given. Then coming to so these are all about pre-malignant or potentially malignant diseases, pre-malignant lesions and the conditions. Then coming to malignant epithelial neoplasms. So malignant epithelial neoplasm. So the malignant tumors which are derived from epithelium are squamous cell carcinoma, verrucous carcinoma, basal cell carcinoma, and malignant melanoma. And then what is squamous cell carcinoma? It's otherwise known as epidermoid carcinoma. It's a malignant epithelial neoplasm exhibiting squamous differentiation as characterized by formation of keratin and presence of intercellular bridges. Most common malignant, this is the most, squamous cell carcinoma is the most common malignant neoplasm of the oral cavity. It comprises about 90 to 95% of or oral malignancies. Then prevalence of common cancers, males, lung and stomach, lung cancer and stomach cancer, go to male prominence, and females breast and cervix. And head and neck cancers are the third most common group of malignancy, and oral cancer is the most common group in head and neck cancers. Okay, etiology. The cause of oral squamous cell carcinoma is multifactorial. No single agent or factor is identified for squamous cell carcinoma. Both extrinsic and intrinsic factors may be involved in carcinogenesis. So, extrinsic factors are external agents like tobacco smoke, alcohol, syphilis, and sunlight. And intrinsic factors are systemic or generalized states like malnutrition and deficiency anemia, and in sometimes immunocompromised patients also prone for squamous cell carcinoma. However, heredity is not a factor in oral squamous cell carcinoma. Many cases are preceded by precancerous lesions like leukopenia. Etiology, the risk of oral etiology, the risk of oral cancer in smokers is dose dependent. And the risk is also increased the longer a person smokes. And the risk of palatal cancer is greatly increased in persons who practice reverse smoking. And pan or betel quid is a combination of aracanid, betel leaves, slaket lime, and sometimes tobacco. The slaket lime enhances absorption of other substances into the mucosa also. And the risk of oral cancer is increased by 8% in those who chew pan. And alcohols got a synergistic effect with tobacco in causation of oral cancer. And syphilis is not relevant in present times because syphilis is treated in early stages with the good antibiotics. However, syphilis used to be treated with arsenic, and it may have been cause for high incidence of cancer associated with syphilitic processitis. And next is sunlight or actinic radiation. This was significant only for basal cell carcinoma of the lips. The incidence is higher in males who are generally more exposed to sunlight, and it is commoner in fair-skinned persons. And come to the orodental factors, poor oral hygiene, faulty restorations, sharp teeth, and ill-fitting dentures are cofactors. And these are synergistic factors with the tobacco habit. And diet and deficiency states. Dietary deficiencies play a contributory role in the development of oral cancer. And a relationship between sideropenic dysphagia and oropharyngeal cancer is well recognized. And certain deficiency states like anemia, vitamin A deficiency, all this makes the epithelium atrophic, and thus it is more vulnerable to the action of carcinogens like tobacco and alcohol. Sideropenic dysphagia or Plummer-Vinson syndrome or Patterson-Kelly syndrome is a precancerous condition. It is characterized by iron deficiency anemia, generalized fatigue, and difficulty in swallowing due to formation of esophageal verbs, angular chelosis, mucosal pallor, smooth glossy tongue, etc. And usually it is associated with the elevated risk of squamous cell carcinoma of the esophagus or pharynx and posterior mouth. And these malignancies develop at an early age in persons with iron deficiency anemia. This is the significance of the syndrome. These persons have impaired cell-mediated immunity. And role of viruses, also oncogenic viruses. The viruses induce cancers by altering the DNA and chromosomal structure of host cells and then inducing the cells to proliferate in an uncontrolled manner. And HPV is implicated in etiology of oral cancer, HPV 16 and 18. For papilloma, HPV 6 and 11. Here, HPV 16 and 18 are the high-risk strains. They are the high-risk strains for HPV. And viral proteins is release viral proteins like E6 and E7. They are responsible for carcinogenesis. And however, in the reports, it is HPV-related oral cancer has got a better prognosis. And another etiology is immunosuppression. Malignant cells may not be recognized and destroyed at an early stage. People with the AIDS, this immunosuppressive therapy for organ transplants, autoimmune diseases are at autoimmune diseases are at higher risk. And genetic abnormalities. Normal proto-oncogenes may be converted into oncogenes by viruses, chemicals, or radiation, and these oncogenes stimulate cell division. Thus, oncogenes are involved in irrigation and progression of various neoplasm, including oral squamous cell carcinoma. Genetic abnormalities, tumor suppressor genes may be inactivated due to mutation of cell. Thus, they permit genetically abnormal cells to progress in the cell cycle. And the accumulation of these abnormal cells will ultimately result in tumor formation. That is how the tumor develops. And P53, RB gene, and P16 are commonly mutated tumor suppressor genes. Coming to the clinical features, a varied clinical presentation for all squamous cell carcinoma, exophagic growth, actually fungating papillary or verrucous type of growth, and endophytic or invasive burrowing or ulcerated lesion, leukoplakic patch like erythroplakic patch or erythroleukoplakic patch. And the exophatic lesion shows irregular fungiform papillary or verruciform projections above the surface. It may appear red to white depending on the keratin and vascularity. The surface may be ulcerated on palpation, the edges are hard and indurated. Induration means infiltration of these tumor cells in the connective tissue. The endophytic lesion shows a depressed area which may be ulcerated in the center, and the surrounding border has a rounded or fold appearance due to downward and lateral growth of the tumor under the epithelium. When the tumor spreads into the bone in radiographically, get moth-eaten appearance or ill-defined radiographic picture. And if nerve innervation is there, paresthesia or numbness. And coming to the histopathology, oral squamous cell carcinoma arises from dysplastic surface epithelium, as you all know, which is characterized by invasive islands. Dysplastic cells may infiltrate the basement membrane and invade into the underlying connective tissue. Extension of this dysplastic epithelium through the basement membrane into the connective tissue may occur, and these dysplastic cells sometimes may extend into the adipose tissue, muscle, or bone. And cells also surround and destroy blood vessels and lymphatic cells. The dysplastic epithelium induces immune response in the connective tissue, which is seen as inflammatory reaction along with this infiltrating tumor islands. Sometimes areas of necrosis may be seen depending on the stage. And dysplastic epithelium induces formation of blood vessels that is called neoangiogenesis. It can also induce dense fibrosis sometimes in the connective tissue that is called desmoplasia. Histologically, squamous cell carcinomas are graded into well-differentiated, moderately differentiated, and poorly differentiated. That is called broadest grading. And this differentiation refers to the extent to which the tumor cell resembles the parent cell. I forgot to tell you the parts of a neoplasm or parenchyma and stroma cells. Parenchyma means proliferating tumor cells, and stroma means supporting structures. Differentiation refers to the extent to which the tumor cell resembles the cell of origin, both structurally and functionally. And this resemblance of the tumor cells to squamous epithelial cells and the amount of keratin they produce help to determine the histological grade of the tumor and with the epithelial atypia. Well-differentiated squamous cell carcinoma, most of the tumor cells are identified as squamous epithelial cells. Large amount of keratin is present, seen in the form of keratin pearls of varying sizes, and dysplastic cells. So features like cellular pleomorphism, nuclear hyperchromatism, increased nuclear cytoplasm ratio, individual cell characterization, and abnormal mitosis. The surface epithelium, dysplastic surface epithelium, restricted basement membrane. You can see islands of squamous cells with keratin pearl formation. This is well-differentiated squamous cell carcinoma. Then coming to moderately differentiated squamous cell carcinoma, these cells still resemble squamous cells, but similarity is less pronounced. And the islands of clusters of cells are smaller in size. Some cells are seen lying free in the connective tissue. And the amount of keratin formation is also reduced. See, islands and strands of squamous tumor cells intermingling with inflammatory cells, just got a slight resemblance to the squamous epithelium. Then poorly differentiated squamous cell carcinoma, the tumor cells show no similarity with the squamous epithelium, and it is difficult to even identify them as epithelial cells. Keratin formation is almost absent, with tumor cells showing all dysplastic features are scattered throughout the connective tissue, and then cells show an even greater lack of cohesiveness. See? Round to ovoid appearing and some spindle appearing cells. There is no resemblance to the squamous cell or parent cell. Clinical staging. Like take 10 more minutes, 15 minutes. Can I take 15 minutes?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Okay. So coming to the clinical staging refers to clinical evaluation of the extent of disease. No, it helps clinician to plan treatment. That is the importance of staging, clinically staging the condition. It helps to evaluate various treatment options also, and helps in standardizing the disease for communication between doctors. And so commonly used system is TNM staging. I think it is given in the textbook. What is TNM staging? Just go through that. Okay, T primary tumor size, N node, regional lymph node, and M distant metastasis. Okay, this can be asked as short essay or short question. If that's short answer question, you just write this page only. Okay, stage 1, stage 2, stage 3. Treatment and prognosis. Prognosis of oral squamous cell carcinoma on all locations except the lower lip is poor. Poor prognosis is due to a late diagnosis and late initiation of treatment. And survival rate depends on clinical stage of the disease and intraoral site which is involved. And treatment modalities for surgery, radiotherapy, or a combination of both. Chemotherapy used as adjuvant therapy and targeted therapy is the advanced management for the oral squamous cell carcinoma. Small tumors are treated surgically along with the neck dissection. Larger tumors receive combined therapy, and if lymph nodes are palpable, elective neck dissection is done along with neck irradiation. And sentinel lymph node biopsy is also done if occult metastasis is suspected. Prognosis is determined by 5-year survival rate. It varies from 68% for stage 1 tumors to 27% for stage 4 disease. And in case of lower lip, survival ranges between 83% and 47%. Coming to verrucous carcinoma, the synonym for verrucous carcinoma is Ackermann's tumor. Why? Because Ackermann introduced the term verrucous carcinoma in 1948, is otherwise known as snuff dippers cancer. It is also associated with the habit of chewing tobacco, smokeless, and snuff tobacco, and ill-fitting dentures. And it presents 1 to 10% of all squamous cell carcinomas, also reported in non-Jews, so may be associated with HPV 16 and 18. Clinical features, it's more common in men of older age group, about 16 to 70 years. The site of lesion corresponds to site where the tobacco quid is placed. And most common sites are buccal mucosa, lateral border of tongue, retromolar region, vestibule, and gingiva. Other sites are alveolar ridge, palate, and floor of mouth. Lesion usually appears as well-demarcated, painless, thick plaque with the papillary or eruciform surface projections. Okay, lesions are usually wide due to heavy keratinization. And some lesions appear red to pink if there is less keratin and a significant inflammatory response. As the lesion grows into the underlying tissue, bone, cartilage, muscle, and salivary glands may be destroyed. Microscopically, it is but a benign appearance at the surface is papillary or verruciform. Typically, there are elongated wide ridges that push into the deeper connective tissue. Therefore, verrucous carcinoma is an exophytic and endophytic growth. So it is characterized by proliferation of the stratified squamous epithelium in a finger-like manner. And between the clefts, you get paracardial plugging. Because of this paracardial plugging, the epithelial reticulus become pushed into the underlying connective tissue. Because of this, the connective tissue may respond to that margin and get intense inflammatory reaction in the connective tissue. And there is not that much cellular epithelium. So this parakeratin is the histopathologic hallmark of Parakeratin plugging is the histopathologic hallmark of verrucous carcinoma. See, the epithelial ridges appear to be pushed into the underlying connective tissue, and some sort of inflammatory reaction is there. In few cellular atypia. Okay. And treatment and prognosis. This is a low-grade malignancy. Treatment of choice is surgical excision. Chemotherapy may be used as adjuvant, and prognosis is much better. Then squamous cell carcinoma. Coming to basal cell carcinoma, is also a malignant tumor which is derived from epithelium and is otherwise known as rodent ulcer. So basal cell carcinoma or rodent ulcer. It's got rolled out margins with the central ulceration. This is the most common skin cancer. 80% of basal cell carcinoma occur on the skin of head and neck region. It's a locally invasive malignancy which does not metastasis. Pathogenesis of squamous cell carcinoma is believed to arise from the pluripotent stem cell compartment of basal layer of epidermis, as well as follicular structures. That means hair follicle stem cell just below sebaceous gland duct. Etiology: chronic exposure to UV radiation, sunburns, and freckles in childhood, and increased risk. Chemicals such as arsenic, genetic skin disorders, and immunocompromised patients. Painter features: it is usually seen in adults with a fair skin complexion, usually in 4th decade of life. Male to female ratio is 3:2, and most frequently it is seen in the middle third of face. It's a locally invasive, slow-growing epithelial malignancy which does not metastasis. Basal cell carcinoma does not occur on oral mucosa except by extension. There are different types of basal cell carcinoma is there. This is a histopathologic feature of basal cell carcinoma. It's follicles of malignant epithelial cells with the peripheral columnar cells and the central polyhedral cells with the clefting. It's because of the presence of mucopolysaccharides. The cleft formation known as artifactual retraction may be seen between the epithelial lines and the connective tissue due to shrinkage of mucin during tissue processing. In pigmented basal cell carcinoma, benign melanocytes are present around the tumor, produces large amount of melanin, and superficial basal cell carcinoma, buds of basaloid cells attached to the surface of epidermis. Treatment depends on the site and size of the lesion. Small lesions less than 1 centimeter are treated by surgical excision and laser ablation. This 5 millimeter margin of normal tissue is expressed. And why it's called basal cell carcinoma? Rodent ulcer, because it is marked by rodent. Rodent is nothing but that is rat. It's called rodent ulcer. Okay. Then coming to malignant melanoma, that's also a malignant neoplasm which is derived from oral mucosa or oral epithelium, and it is derived from epidermal melanocytes and developed de novo or from benign melanocytic lesion. This is the third most common skin cancer, and oral mucosal melanoma is rare as compared to skin lesions. The mucosal melanomas are diagnosed at later stage and are more aggressive than the skin lesion. Etiology of etiologic factors are sun exposure, relative with history of melanomas, fair complexion, light-colored hair, tendency to sunburn easily, and history of several episodes of blistering sunburn in childhood, personal history of congenital or dysplastic nevus. So the developmental melanoma, we've got a 2 growth phase. Not all melanoma show both phases. Some are in a vertical phase only in the beginning. And the radial growth phase, that is initially spread horizontally in the epidermis, and this phase may last for several years. There is no metastasis for radial growth phase. And vertical growth phase, there the neoplastic cells proliferate into the dermis. It reflects increased virulence of cells or decrease in the host immunity, where the metastasis is more common. These are the clinico-pathologic types of melanoma: superficial spreading, nodular, lentigo, acral, mucosal lentiginous, and melanotic melanoma. Thank you, features this book, textbook, nodular. What is the melanotic melanoma? It's an erythematous working, sometimes broader non-visible histological examination provide the right diagnosis with is without any melanin pigments. S100 and HMB45 immunohistochemical markers before the diagnosis. The histopathologic features of malignant melanoma. In histopathology, phagocytoid spread with within the epidermis, sometimes known as buckshot scatter. When melanocytes penetrate the basement membrane, a folded host response may occur. In vertical phase malignant, epithelioid melanocytes proliferate in the connective tissue stroma and melanin pigment is scanning. This histopathology photomicrograph of a malignant melanoma. See the difference between nevus should be differentiated from malignant melanoma. So here the ABCD rule is applicable to differentiate nevus and malignant melanoma. It can be asked as a short question. There is asymmetrical growth of lesion. One half does not match the other half. Asymmetrical growth of lesion. One half does not match the other half. B, border irregularity with the blurred, notched or ragged edges. C, color variation from red to brown to black to blue in the same lesion. D, diameter larger than 6 mm. E, the lesion is raised or elevated above the surface. This is ABCDE rule. And the treatment of cutaneous malignant melanoma is surgical excision. Like the lymph node dissection is performed if regional nodes are involved, sentinel lymph node biopsy. If regional lymph nodes are palpable, chemotherapy, immunotherapy, and radiation therapy for cutaneous melanoma. However, oral melanomas have a very poor prognosis than cutaneous melanoma. And younger patients have better survival than older patients. The 5-year survival rate for such tumors is approximately 7%, and inversion to depth more than 0.75 mm indicative of poor prognosis. So the clinical classification, it is there in the textbook. Please go through the frequently asked questions. Define pre-malignant, potentially malignant disorders of oral cavity. Describe in detail etiology, clinical features, and histopathology features of oral squamous cell carcinoma. We try to answer to the question. Define potentially malignant and describe in detail etiology. Just write the etiology, clinical features. Just write the clinical features and histopathology of oral squamous cell carcinoma. You need to draw diagrams also. Please write according to mark and specifically answer to the questions. Okay. And another question that can be asked from this is define pre-malignant lesions, enumerate pre-malignant lesions, and discuss etiopathogenesis, clinical features, and histopathology of leukoplakia. And classify red and white lesions, describe clinical features, histopathologic features of leukoplakia, and add a note on its malignant potential. Short essays, short essays are etiopathogenesis of oral squamous cell carcinoma, clinical and histological features of leukoplakia, oral melanotic nevus. Now it is given under developmental anomaly, clinical features and histopathology for lupus carcinoma and squamous cell carcinoma, and short note, possible short that has been asked in the question papers, histopathological features of oral submucous fibrosis, epithelial dysplasia, ABCDE rule, rodent ulcer, TNM staging character, acanthoma or self-healing carcinoma, and coilocytes can also be asked. I hope it is clear for you. With this limited time, I could do some justice for you. Okay, thank you so much for giving me this opportunity.
Thank you, ma'am, for a very informative session. A vast topic was made comprehensive to be well presented in an examination. Thank you, ma'am. We have no queries in the chat box. Dear students, if you have any queries, you can also post in the WhatsApp group and we will revert to you. Thank you, ma'am.
Thank you. Thank you.
Thank you, Dr. Veena. Now we are moving on to our next session. The next session is on diseases of salivary glands. I'm delighted to introduce and invite a great teaching laurel from Annoor Dental College, Dr. Priya Thomas, reader in the Department of Oral and Maxillofacial Pathology with more than 10 years of teaching experience. She graduated from VS Dental College, Bangalore in 2003 and completed her PG from Savida Dental College in 2011. She holds a postgraduate diploma in bioethics from PSG Medical College, Coimbatore, currently a research scholar in molecular biology with Savida Dental College. She is the highest scorer in dental materials at institutional level for BDS, first rank holder in Kuha certificate program in healthcare counseling. She was awarded the Best Teaching Award 2019 at national level by Indian Education Awards IIT Patna. She has guided UG projects under ICMR and Kerala State Council of Science and Technology. She has various national and international publications and is also a reviewer of many scientific journals. Wholeheartedly, I welcome Dr. Priya Thomas. Over to you, ma'am.
Thank you, Dr. Nidhi, for your kind introduction. Good morning, dear students. I'll go to screen sharing. So after a long session of epithelial pathology, we'll move into the next topic for the day, that is diseases of salivary gland. Now, before we go into the different diseases, just to tell you about the basic histology, this is way back to your first year BDS. If you remember, your salivary gland is basically divided into your secretory unit and your ductal system. So the secretory unit is basically your acini. That is, it has both serous acini as well as a mucous acini. Along with that, you have the entire ductal system, which is divided into your intercalated duct, you have your striated duct, and you have your excretory duct. Other than this, you have some specialized cells within this acini. That is your myoepithelial cells. They are a specialized group of cells which is basically present over your acini and also over the intercalated duct. Another way of looking at these cells is you can divide them as luminal cells and abluminal cells. These terminologies I'll be using during the presentation. So you can divide them as luminal as well as abluminal cells. Now, luminal cells are those cells which is present towards the lumen. So that will include your acini as well as the entire ductal cells. The abluminal cells are those which are away from the lumen. So those will be your myoepithelial cells, and you have some amount of basal cells. That is your intercalated duct reserve cells you have basal cells. So these are considered as your abluminal cells, that is those who are away from the lumen. So your diseases of salivary gland is basically divided. So in this presentation, I'll be dealing with two portions which are the different diseases, that is the neoplastic diseases as well as the non-neoplastic diseases. The neoplastic diseases are divided into basically the epithelial tumors, and also you have your mesenchymal tumors. Along with that, you have another group of tumors which you can see within the salivary gland, that is your metastatic tumors. The epithelial and the mesenchymal, as Sudha ma'am had already talked, is further divided into your benign and malignant tumors. As per the WHO classification, if you look, these are the different tumors you have been, or there has been a category under benign and malignant. So under benign epithelial tumors, you have the commonest ones, that is pleomorphic, Warthin's, oncocytoma, and all the other adenomas. Under malignant, you have mucoepidermoid, adenoid cystic, acinic cell adenocarcinoma, carcinoma X pleomorphic adenoma, polymorphous low-grade adenocarcinoma, and the others. So the ones which is highlighted here in green, these are the ones which is important for you from your exam point of view. That is why this is being highlighted here. So from exam point of view, you have to remember these tumors. The other tumors which you have is the mesenchymal tumors. Now, these are tumors which you've already read under your connective tissue. The same tumors you can see within the salivary gland. So your benign ones are basically the hemangioma, the schwannoma, neurofibroma, and then you have the malignant ones, that is your sarcoma. So you have fibrosarcoma, malignant fibrohistiocytoma, rhabdomyosarcoma. Along with the malignant ones, you have your lymphomas, that is both Hodgkin's and non-Hodgkin. So all these mesenchymal tumors can be seen within the salivary gland. And then you have the third group, that is your metastatic neoplasms. So similarly, you can have whatever you read in epithelial pathology now, those tumors will be present within the salivary gland. So you can have a metastatic lesion of your melanoma, your squamous cell carcinoma, even renal cell carcinoma, thyroid carcinoma can also be visualized within the salivary gland. We'll move on to the main portion from your exam point of view. So I'll be dealing the entire session only from your exam point of view. So your benign salivary gland tumor, which is most commonly asked for you, is your pleomorphic adenoma. It's otherwise called as a benign mixed tumor. So there's another terminology used here. It's called as a benign mixed tumor. Now, this is a question which can be asked for you from during the university. So the question goes, classify salivary gland tumors, which we have already dealt, and discuss in detail about pleomorphic adenoma. Now, whenever you answer this question, see to that you have these points in your answer. You should not miss these headings. So the entire answer should be framed under these headings. That is a little bit introduction, the different clinical features, which is related to the demography, the site, the clinical presentation of the tumor, the histogenesis or the pathogenesis, the histopathology, and the treatment and the prognosis aspect of it. So remember, the entire answer should be framed under this if it is an essay question. So pleomorphic adenoma, it's the most common neoplasm. And why it is called as a mixed tumor? Why the word mixed? That is because within the histopathology, it has two components. It has both epithelial components as well as it has connective tissue components. Why the word pleomorphic adenoma? Why that term is used? Why? Pleomorphic indicates its diverse histological patterns. So if you look at the tumor in histopathology, you can see a variety of patterns within the tumor. That is why the term pleomorphic is used here. So along with the histological pattern, it has a morphological complexity. You can see a lot of patterns within the tumor. Now, how is this morphological complexity or the diverse pattern you will get within the tumor? That is because the tumor cells will undergo differentiation. So you have differentiation of the tumor cells. Along with that, you have the connective tissue components. That is, you can see fibrous areas, hyalinized areas, myxoid, chondroid, bone-like areas. Now, these areas will occur within the tumor as a result of metaplastic change, or it could be the byproducts of these tumor cells. So that is how you get different areas within the tumor. The clinical features, when you look at the age group, this tumor is common to any age group. It can occur in any age group, but most commonly it is seen between 30 to 50 years. And this tumor is a primary tumor to develop early childhood. So you can see pleomorphic adenoma even early in the childhood days. Gender, very common to females. That is, it has a slight female predilection. But this is something which you can write for all your salivary gland tumors. So this is a thing which you can keep in mind. Most of the salivary gland tumors, which is important for you from exam point of view, the predilection is always for females, except one tumor, which I'll be telling you. Other than that, everywhere it is females, which has a higher predilection. Again, site, similar. It holds for all the salivary gland tumors. Parotid is the most commonest area to be affected. And also you can have the presentation of these tumors within the minor salivary glands. The clinical presentation of the tumor. It usually presents as an asymptomatic nodule or a growth or a mass. So it is painless and it is slow growing. Again, something which is common to all the salivary gland tumors. All the salivary gland tumors, most of it which you have to study is a slow growing mass. The tumor mass will present as a slow growing nodule or a mass or a swelling. Now, within the parotid gland, how the tumor appears. Usually, if you remember, the parotid gland has got two lobes, that is the superficial lobe and the deep lobe. Now, it affects both the lobes. Most commonly, it will be affecting the superficial lobe. And when it affects the superficial lobe, you will have the swelling overlying the ramus of the mandible, and it will be present in front of the ear. When the tumor grows in size, the larger tumors will become less mobile. And only 10% of these tumors will be affecting the deep lobe. So most commonly, it is going to affect the superficial lobe. And if it is a superficial lobe, you will see the tumor just in front of your ears. If it is a deep lobe, it is just 10%, which is going to be present beneath the facial nerve. And a deep lobe, you can see these tumors extending into the pharyngeal wall. So you can have the extension of these tumors inside or into your pharynx area. Now, there is something called as a dumbbell tumor, or it can be called as a dumbbell shape. Now, even pleomorphic adenoma, if you look at in its clinical presentation, you can call it as a dumbbell tumor. That is because in clinical scenario, because of its growth towards a mesial direction or the medial direction, it assumes a dumbbell shape. Now, if you look at this resembles a dumbbell because the growth is towards a medial aspect. So that is why it is called as a dumbbell tumor. To elicit the pleomorphic adenoma clinically, there are three different signs. One is called as a positive curtain sign. That is, these masses are unmovable above your zygomatic bone. So if it affects the parotid gland, if you try to move the mass above your parotid, above your zygomatic bone, these masses does not move. So when it doesn't move, it is considered as a positive curtain sign. Then the other thing which you can witness for this tumor is a raised earlobe, because it's in front of the ear and the earlobe will be raised. When it affects the deep lobe, you will have the deviation of the uvula as well as the pharyngeal wall. For the minor salivary glands, the most common site to be affected is the palate, followed by the other sites, that is the lip and the buccal mucosa. Now, when it affects the palate, it is more common to the hard palate and usually on the lateral aspect of the hard palate. It appears or it presents as a smooth surface dome-shaped swelling. So that is how you're going to see it. You can see within the clinical photograph, it appears as a smooth surface dome-shaped swelling. And the ulcerations can occur on the surface of the tumor as a secondary change. That is, if there is some trauma, the trauma can induce a secondary change and it can undergo ulceration. Usually the palatal tumors are immobile, and when you compare it with the tumors which is going to be present within the lip or the buccal mucosa, they can be easily moved apart. So that is a difference. Palatal tumors are considered to be immobile. That is because of the histological portion or histological components of your palate. Moving on to the histogenesis. When you look at the histogenesis, it arises from basically myoepithelial cells as well as the reserve cells of your intercalated duct. So your pleomorphic adenoma will originate from two cells, that is myoepithelial cells and the basal cells or the reserve cells of your intercalated duct. It is your intercalated reserve cells which has a property to differentiate into the ductal cells as well as the myoepithelial cells. And here, it is a myoepithelial cells which is going to give the major portions of your pleomorphic adenoma. That is, it can undergo metaplasia, and that is the one which is going to bring about the diversity, the histological patterns or the morphological diversity within the tumor. So these myoepithelial cells are not normal myoepithelial cells. They are considered as modified myoepithelial cells. And otherwise, they can be called as Cinderella cells. So that's a term which is used for these cells here, because just like your Cinderella, how she changes her form, these myoepithelial cells can change its form. So that is why these are considered as a modified myoepithelial cells, or they can be called as the Cinderella cells. The other factor which can produce pleomorphic adenoma is a genetic abnormality. So you have your genes being affected, basically the pleomorphic adenoma gene 1 and your HMGA2 gene. So these are the two genes which is going to be affected within pleomorphic adenoma. Now, this is just a morphological, how the morphological variety you get. This is just a flow chart which is put for you so that you will understand it easily. As we have discussed, you have the combination of ductal cells, myoepithelial cells, and intercalated duct cells, the reserve cells. Now you can have proliferation in these different patterns. The diversity which you see is because of all these changes. The ductal and the myoepithelial cells together can proliferate to form ductal areas within the tumor. It will proliferate and form ductal areas within the tumor. And these ductal areas will be surrounded by the myoepithelial cells, which is called as your swarm of bee appearance. Myoepithelial cells alone can proliferate. So the modified myoepithelials alone can proliferate. The only cells, the only myoepithelial cells you will see within the tumor. So in areas, you can see only these myoepithelial cells. And you can get 3 different patterns of myoepithelial cells or 3 different shapes. That is the plasmacytoid myoepithelial cells resembling the plasma cells. That's why it's called as plasmacytoid, because it resembles the plasma cells. You can have spindle, or you can have angular type of myoepithelial cell proliferation. Then you can have the byproducts of these cells. The byproducts, you will get 2 byproducts within the tumor. That is a basal lamina as a byproduct, wherein you get hyalinized areas within the tumor, or you can have the secretion of glycosaminoglycans, which will produce a myxoid stroma within the tumor. That is, you get loosely arranged areas, which is your myxoid areas. The myoepithelial cells can undergo metaplastic change. Now, the metaplasia can be a stromal metaplasia or connective tissue metaplasia, or it can be a squamous metaplasia. If it is stromal, you get chondroid areas or cartilaginous areas, you get bone-like areas, and you get adipocytes within the tumor. Or it can be the squamous, wherein you can have the production of keratin pearl formation. The chondroid areas can occur within the tumor as a result of vacuolar degeneration, not only because of metaplastic change, but also it can occur within the tumor because of a degenerative process. So this is a way in which you get the entire histopathology of the tumor, or the histological diversity of the tumor. That is why these cells are called as centrilla cells. This is just a diagrammatic representation of what I had already told you. You have your products, and this is the way you get your hyalinized area, the myxoid matrix, the chondroid areas, the squamous metaplasia, and all your stromal metaplasia. And this is what I was talking, that is a ductal proliferation with myoepithelial cells surrounding it. That is your swarm of bee appearance. It looks like as a bees are swarming around a honeycomb. And the proliferation of myoepithelial cells alone, that is plasmacytoid, spindle, or angular, or you can have a mixture of all these type of cells. Looking at the histopathology, it's a well-circumscribed tumor. Remember, it's a benign tumor, so it will be encapsulated. It's known for its cytological morphology and architectural diversity. And when you look at the tumor as a whole, you will have the epithelial components and you have the mesenchymal components. So the epithelial components are basically made up of the glandular epithelium, that is the ductal areas, and the myoepithelial cells. And these epithelial component will be present in duct-like areas or cyst-like areas. You can have areas just as islands or sheets of cells. And the myoepithelium, as we had already discussed, it will be present in these 3 forms. Now, if you look at this picture, you can see they resemble the plasma cells. The nucleus is eccentrically placed or pushed to one end. That is why it is called as a plasmacytoid cells. So if it is present as islands or sheets, you will see only group of these cells together. Like I had already told you, you will get the swarm of bee appearance. That is, you have thick collars of these myoepithelial cells around the ductal area. So this is the histopathology. If you look, this is a duct-like pattern around which you have your angular cells or myoepithelial cells around the duct-like area. So this is called as a swarm of bee appearance. Then within the duct, you get eosinophilic secretory material. So these produces microcystic area. So within the ductal-like structures, you get eosinophilic secretory material. At times, you can see bilayered ducts. So other than a single layer duct surrounded by these myoepithelial cells, you can get double layered duct or bilayered duct. Now, when it is bilayer, the outer layer of this bilayered areas will be represented by clear cells. Now, these clear cells are basically your myoepithelial cells alone. So you have one presentation like this. You have areas with bilayered duct-like areas wherein the outer layer is going to be clear cells. And what happens is these myoepithelial cells will start to secrete their secretory material. So once they start to secrete the secretory material, the cells will be moving apart because the material will be secreted in between. So that is going to separate the cells into either groups or narrow strands of the cells. So that is how you get the pattern. The material will be present in between that is going to separate the cells either as strands or as small groups or islands. So this is how it is, the duct-like area with the secretory material, and these are your secretory products which is going to be present in between. So your secretory products, as we had already told you, you have loosely arranged areas. Those are your myxoid areas. You have hyalinized areas, which is going to be pink in color. Then you have the metaplastic chains, that is squamous metaplasia with keratin pearl formations. You can see in this picture, keratin pearl is being formed. And you have other areas like bone, cartilage, your adipocytes. And also the cartilage is because of degeneration. It's not necessarily because of it's a byproduct or it's basically the metaplastic change. It can be because of a degenerative procedure. This is a diagram which you have to draw for your exam. It should be there in histopathology. So this is what it is, your ductal areas with secretory materials, swam up the appearance, the chondroid areas, the myxoid areas, which is thin, loosely arranged thing, and fibrous areas. Other than this, within the FNAC, you can see the deposition of certain crystalline material. Now, crystalline material, there are two kinds which you can get within pleomorphic adenoma, that is tyrosine-rich crystals, which is basically in the shape of a flower. So you get a flower-like or a petal-shaped clusters, and these are basically structureless mass which is surrounding a central core. And the other kind of crystalline material which you can get is a collagen-rich crystalloid, which is basically a needle-shaped structure. So these are basically seen in FNAC. Then you can divide the entire histology into 4 types. So this is based on the components which is present within the tumor matrix. So the components which they have considered is the myxoid areas and the cellular components. So based on that, they've divided it into 4. It could be principally myxoid, more of myxomatous areas. Then the next thing which you can have is a mixture of myxoid areas and cellular components in equal proportions. Then it goes to a slightly higher grade, that is, it becomes cellular. And finally, the last grade is extremely cellular. You see more of cells rather than the tumor matrix areas, that is the mesenchymal portion. So it will be more of cells with less amount of myxomatous areas or the byproducts of the tumor. Treatment, you have to do an excision. That is most of the treatment, that is a common treatment which is carried out for most of the salivary gland tumors. So you have to do a surgical excision. Prognosis, since it's a benign tumor, it's going to be really good. But at times, you can have a malignant change of pleomorphic adenoma. It can change into malignancy. It is very, very rare. Now, if it changes, it is called as carcinoma ex pleomorphic adenoma. That is, an existing tumor of your pleomorphic adenoma is going to change into a malignancy. So within this, you will tend to see the normal histology, what was seen within the benign pleomorphic adenoma. But along with that, you will have malignant changes or dysplastic changes. You will see hypochromatism, pleomorphism, nucleus cytoplasmic ratio being altered, mitotic figures. So all this you will see within carcinoma ex pleomorphic adenoma. At times, you can have metastasis also. So long-standing lesions can become malignant and also it can undergo metastasis. So the common areas which it will undergo metastasis is the lungs and the regional lymph nodes. So this is what was dealing with an essay question of pleomorphic adenoma. The next thing in your benign tumor is Wathen's tumor. Now this is commonly asked as either a short note or an essay. Again, you follow the same pattern of answering. Wathen's tumor is otherwise called as papillary cyst adenoma lymphomatosum. Break up the terminology here. Now, this is a cystic area. So within the tumor, you have a cyst-like area. That is why it is called a cyst adenoma, into which you have the papillary proliferations. So the epithelium is going to proliferate like your finger-like projections, or you have a papillary projection into the cyst-like area. And you have another component here, that is lymphomatosum. You have lymphoid tissue or lymphoid structure within the tumor. So this entire terminology is based upon the histological components. Cyst-like area with papillary projection and with a lymphoid component. The theories behind or how you get this tumor It is basically the most accepted theory. What they have proposed is the presence of heterotrophic salivary gland tissue within the parotid lymph nodes. So if you remember, you have the presence of lymph nodes within the parotid capsule. That is basically a periparotid lymph node. So there is a possibility that during your developmental stages, the salivary gland tissue can get embedded within the parotid lymph node. So that is a way in which this tumor can originate. The other theory which has been proposed is the neoplastic proliferation of parotid ductal epithelium. The ductal epithelium can undergo a malignant change. I mean, it can become a neoplasm. And secondary to that, there'll be a reaction within the body wherein you get your lymphoid tissue. So these are the two theories which is proposed behind Wathen's tumor. And the most accepted theory is the first one. The risk factors which can give rise to Wathen's tumor is basically smoking. So that is because the smoke is being excreted into your salivary ducts. The other things which could produce is your virus. It could be a delayed hypersensitivity reaction and certain genetic abnormalities. Now, since smoking is present as one of the risk factors, remember, it will be more common to males. So this is an exception of the tumor wherein males are going to have a slight predilection. The other salivary gland tumors, it's all common to females. Now, this is considered as a second most common benign tumor of salivary glands. The first is pleomorphic adenoma. It's slightly to the older age group. So this is between 60 to 70 years. And it's exclusive to the parotid gland or the periparotid lymph node. So remember, this tumor is very, very common or exclusive to the parotid gland. But at times, you can get in other areas also. Clinical presentation of the tumor, it's going to be a slow growing tumor. Like I've already mentioned, these salivary gland tumors will have a slow growth. It'll be solitary. It'll be asymptomatic. And it'll be located just beneath the parotid capsule. If it is going to be unilateral, you will have a facial asymmetry. At times, you can have a bilateral presentation of the tumor. Again, it's slightly on the rarer side. And occasionally, you can get pain, pressure, or even rapid growth of the mass. It'll be firm in consistency, but since it's a cystic lesion, you can get fluctuancy also on palpation. Histopathology is important from your exam point of view. Now, looking at the histopathological features, it is a benign lesion, so it is going to be capsulated. So the capsule can be complete or it can be incomplete. When you look at the histological aspects, it has two components. It has an epithelial component and it has a lymphoid tissue component. You have the cyst with papillary projections into the cystic space and with lymphoid matrix with germinal centers. Now, when you look at the papillary layer, it is again bilayered. You have two layers there. So it is a bilayered oncocytic epithelium. You know what are oncocytes, right? So oncocyte is a large eosinophilic cells with granular cytoplasm. And these granules are basically your mitochondria. So here, the papillary layer, the inner layer, that is towards inner layer is the one which represents towards a cystic lumen. So the inner layer is made up of tall columnar cells with eosinophilic granular cytoplasm and with hyperchromatic nuclei. The outer cells that is facing towards the lymphoid stroma is basically an oncocytic triangular or polygonal cells. Along with these cells, you can see spindle-shaped or fusiform basaloid cells. The word basaloid means it resembles your basal cells. So, outer layer of the cells that is towards the lymphoid stroma will be made up of oncocytic polygonal or triangular shaped cells. The ones which is facing the cystic lumen will be made up of tall columnar oncocytic cells. Then within the cystic lumen, you will have the presence of eosinophilic coagulum or amorphous material. Clinically, when you visualize the fluid, it will be chocolate brown in color, which is going to be positive for your PAS stain. The lymphoid component is similar to your lymphoid tissue. You will have lymphocytes with germinal centers. So this is a way, and this is a diagram which you have to put for histopathology. You have the papillary projection into the cystic lumen, two layers, tall columnar cells with polygonal or polygonal or triangular type of oncocytic cells towards the lymphoid stroma and your lymphoid stroma. So this is the histopathology of Watten's tumor. Treatment, again, as usual, surgical excision. Recurrence is very, very rare. Again, malignant transformation. It can undergo malignant transformation. Again, very, very rare. And when it transforms, it will transform into a lymphoma. The next thing we are going to deal with is malignant salivary gland tumors. So we dealt with two benign tumors, that is pleomorphic and Watten's. The next one is malignant, wherein what is important for you is adenoid cystic carcinoma and mucoepidermoid carcinoma. The other two tumors which you have to read is actinic cell carcinoma and carcinoma ex pleomorphic adenoma. So again, the question is an essay question, that is adenoid cystic carcinoma. Follow the same pattern of presentation in your answer. Your adenoid cystic carcinoma is otherwise called as a cylindroma. Now, this term is basically a misnomer, but it can be used because within the histopathology, you get cyst-like areas or cylindrical spaces. That is why this term was used initially, but the appropriate term is always adenoid cystic carcinoma. It's the fifth most common malignant tumor. And when you look at the histogenesis, it originates from ductal cells as well as myoepithelial cells. And when you look at the morphological presentation, you have three types of variants or morphological pattern within the tumor. You have a solid area, that is only the cells. Only cells you will see where you have basal cells and myoepithelial cells and ductal cells proliferating. The other variant which you get is a cribriform pattern. You have cells. Along with that, you have production byproducts of these cells. So you can see glycosaminoglycans and basal lamina that will form microcystic areas or cystic areas within an island. So that is how you get the cribriform pattern. And the third variant which you get is a tubular pattern. Again, it looks like duct-like areas, and these are surrounded by basal cells and myoepithelial cells without intercellular accumulation. So intercellular accumulation or the products is seen only within your cribriform pattern. Within solid areas and within tubular areas, you don't see this intercellular accumulation. Clinical features, again, 5th to 7th decade. It's all in the older age group. Slightly higher for females, like I've told you, this is a gold standard for these salivary gland tumors, except Watten's, the remaining is all females. More common to parotid. Now here what you can see is parotid and submandibular, it occurs in almost an equal proportion. Minor salivary gland to be affected, again, most common is a palatal area. Tongue is the third most common area to be affected by this tumor. Other areas to be affected are your ceruminal glands, that is of the ears, and your lacrimal glands of your eyes. Again, as I've told you, it is a slow-growing swelling. But here you can get, it is not completely asymptomatic, but you can get pain, which is of a low-grade dull ache. And as the tumor increases in size, it is going to be fixed to the surrounding tissues and to the overlying skin. And when it affects the facial nerve, that is within the parotid gland, if it occurs, it's going to cause paralysis. Minor salivary glands, again, it is a swelling, but you can get surface ulceration. If it affects the maxillary sinus, pain will be present and you can see the swelling into the sinus. And if you take a radiograph, when it affects the maxillary sinus, you can see bony destruction. The other areas to be affected are the nasal cavity and the ear canal. So when it affects the nasal cavity and the ear canal, you can have obstruction of the nasal area and also you can have deafness. Looking at the histology, remember the type of cells that you get within adenoid cystic carcinoma is isomorphic basaloid cells. That is the kind of cells which you're going to get. Isomorphic means uniform morphology. You have cells of the same size and shape, and it will be basaloid. Basaloid means it is resembling your basal cell. So you will have cytoplasmic nuclear ratio as 1:1. So the nucleus will be projected more, and it is a blue color nucleus. You will have a hypochromatic nucleus. The microscopic patterns which you get within the tumor, like we had already discussed, it will be cribriform, tubular, solid area. So these are the three different patterns which you will get within the salivary gland tumor. And the cell that you get is going to be an isomorphic basaloid kind of cell. The cribriform pattern is the most common pattern which you get. And the tumor cells is isomorphic basaloid. That means they are dark basophilic. They have a dark basophilic or hypochromatic nucleus with a scanty cytoplasm. So if you look at this diagram here, they're small cells with a blue color, dark blue color nucleus, less amount of cytoplasm, all in uniform size and shape. These will be arranged in nest of variable size and shapes. And within these nest, you have circular or ovoid spaces. These are cyst-like areas. And this will give you an appearance of Swiss cheese pattern or honeycomb appearance. So cribriform pattern is otherwise considered as a Swiss cheese pattern or a honeycomb appearance. And the spaces are formed because of accumulation of extracellular substances, that is your glycosaminoglycans. So this is what you see in histopathology. These are all cribriform areas with your cystic spaces. And this is a high power view wherein you can see some bluish color material within the cyst-like areas. The tubular pattern, why the word tubular? That's because it is the longitudinal sections of the duct. So when you take a longitudinal sections of the duct-like structures, it'll appear like a tube. So that is why it is called as a tubular pattern. So you tend to see longitudinal sections of the tubule. Within the lumen of the tubes or the duct-like areas, it contains mucus substances. And this pattern can occur or coexist with the cribriform pattern. The third pattern which you get is solid pattern, where the tumor cells is going to be arranged in nest or islands. So these are solid cellular areas. You don't tend to see intracellular substance here. So they are solid areas of cells or sheets without spaces or without any tubular structures. Within this, you can see sometimes areas of necrosis, and also you can see cellular pleomorphism as well as mitotic figures. So this is a presentation where you can see solid areas. These are solid areas, see. And sometimes it can coexist with your cribriform pattern. There is another characteristic feature which you have to remember for adenoid cystic carcinoma, that is perineural invasion. These cells have an affinity for the nerves. So majority of it, in most of the tumors, you can see peripheral nerves being involved. So they will invade into the perineural space and sometimes into the nerves also. And usually they invade in concentric circles. You can see this is a neural tissue around which you can see the cells invading in a concentric manner. This is called as your targetoid pattern or targetoid appearance, just like this. So you can see it in circular concentric circles basically. On FNAC, when you take an FNAC of the tumor, again, by doing an FNAC, if you see these areas, it is characteristic of adenoid cystic carcinoma. That is, you get these isomorphic basaloid cells, that is round to ovoid basophilic cells here. Along with that, you tend to see amorphous hyaline globoid structures. Now, these are very much characteristic to adenoid cystic carcinoma. So if by looking at this in FNAC, you can surely tell that it is adenoid cystic carcinoma. Treatment, again, surgical excision. But here, local recurrence is common. With long time duration, it will undergo metastasis. Eventually, it will undergo distant metastasis. And the most common area where it can produce a spread is the lungs and then into the bones. If it is in the palate or maxillary sinus, it can even extend to your brain. Prognosis is slightly poor, and the solid patterns have got the worst prognosis. So that covers with the malignant tumor, adenoid cystic carcinoma. The next thing, what they can ask you from exam point of view is mucoepidermoid carcinoma. Again, if it is an essay, you follow this pattern. If it is short note, based on what they ask, you have to write on mucoepidermoid carcinoma. Most common malignant tumor of salivary gland, and the second most common among all the tumors of salivary gland. Again, seen from 2nd decade to 7th decade. Now, this has a slight higher age range, And this is one of the most common tumors which you can see within children. So one of the most common malignant tumors which is seen in children is mucoepidermoid carcinoma. Again, female predilection. The site to be affected is the major salivary glands. Like I said, it's always the parotid. And also you can get the presentation within the minor salivary glands. If it is a major, it's going to be the parotid. It is asymptomatic swelling where the growth of the swelling takes less than 1 year. Pain, facial palsy is rare and it's seen in high-grade tumors of mucoepidermoid carcinoma. In minor salivary glands, it is the palate that's going to be affected. You can have the presentation of these tumors in other areas, that is the lower lip, the floor of the mouth, the tongue. It presents as an asymptomatic swelling. Sometimes it will be fluctuant and it can have a color tinge to it. So it can appear either as blue or red. Now, when it appears as blue or red, you have to think of two differential diagnoses. That is either mucocele or hemangioma. And then only you have to think of salivary gland tumor. If it's a high-grade tumor, you can have a variety of manifestations. There can be trismus, drainage from the ear, dysphagia, numbness of the adjacent site, and also ulceration. So if you look here, this is a swelling of the palate, and you can see ulcerations on the surface. So this is the way mucoepidermoid carcinoma can present on the palate. Microscopy, again, a variety of cells and a variety of growth patterns that is common to all the salivary glands. Now, from the word mucoepidermoid, okay, that means within the tumor, you will have mucous cells. So this terminology is based on the histopathology. Within the tumor, you will get mucous cells and you will get epidermoid cells. Along with these two cells, you have a third category of cells, that is intermediate cells. So the terminology is based on its histopathology. You will see mucous cells, you will see epidermoid cells, you will see intermediate cells, and also you can see a fourth kind of cells, that is clear cells. Can you hear me?
Ma'am, you're audible.
Yeah. Just a minute.
Ma'am, could you please unmute yourself? Priya ma'am, could you please unmute yourself?
Sorry for the hindrance. There was a slight technical error with my laptop. I'll get back to you. Thank you. So we were talking with the different histological types which you see, or the different types of cells which you see within mucoepidermoid carcinoma. So these are the different cells which you can see: mucus cells, epidermoid cells, intermediate cells, and clear cells. Now, when you look at mucus cells, they are basically, you can see them as different size and shapes. You can see round, cuboidal, ovoid, columnar, or goblet-shaped cells. And the cytoplasm that you see is either hazy or forming. So these cells are large, round, or cuboidal, and the cytoplasm is going to be slightly hazy. It has, and within the cell, it contains mucin. That is why the cytoplasm looks very, very hazy. And basically, you can stain them for mucicarmine, or you can stain them positive for PAS. Now, the next kind of cell which you get is your intermediate cell. That is, they are basically basaloid cells, which is highly, it resembles your basal cells. And these cells are basically those cells which is going to differentiate into your mucus cells or epidermoid cells. So they can differentiate into mucus cells or epidermoid cells. And the next kind of cell that you have is your epidermoid cells. Now, epidermoid cells are basically your squamous cells, or they resemble your squamous cells. So you tend to see them as polygonal cells, or you tend to see them as large squamous cells with intercellular bridges. Okay, you tend to see them as large intercellular bridges. This is what it is, and they rarely form keratin pearl formation. So you don't tend to see keratin pearl like you see this within your pleomorphic adenoma. Within pleomorphic adenoma, you can see keratin pearl formation, but in mucoepidermoid carcinoma, you don't see keratin pearl. The other kind of cell which you get is your squamous cells. That is your clear cells. Your clear cells are going to resemble your squamous cells. That is, they have a clear cytoplasm. So this is the representation of the histopathology. These are your intermediate cells. These are small cells with hypochromatic nucleus. Then these are your mucus cells. The other cells which you see with clear cytoplasm are your clear cells, and this is your epidermoid cells. Epidermoid means resembling squamous cells. That is polygonal cells with intercellular bridges. So this is how you get the different cells within your mucoepidermoid carcinoma. Patterns, what you get are cyst-like structures. You can get solid areas, and you can get a combination of these patterns. Now, if it is cyst-like structures, it is going to be lined by mucus cells or columnar cells. And these cysts can rupture. They can liberate the content into the surrounding connective tissue. So when they liberate the content into the surrounding connective tissue, they are going to evoke inflammatory reaction. So remember, whenever you have something foreign within the connective tissue, it is a cellular material, it's contained in a space, and when it is liberated to the connective tissue, automatically your body will respond to it, and it will produce inflammatory reaction. The other areas, like we said, you can get solid areas. Again, solid areas means it's only cells. So within solid areas, you will get epidermoid cells, intermediate cells, and mucus cells. So this is in hierarchy level. What I put here is in a hierarchy level. So if it is solid, you will get more of epidermoid cells. Then is intermediate and less amount of mucus cells. Now, this is important for your exam point of view. They usually ask the grading of mucoepidermoid carcinoma. The grading of mucoepidermoid carcinoma is based on 3 factors. That is the amount of cyst formation. You look at the number of cystic spaces which is present, the degree of cytological atypia, how much of atypia you have, and also the number of mucus cells, epidermoid cells, and intermediate cells. So this is your grading criteria: the number of cyst formation, the degree of atypia, and the number of mucus, epidermoid, and intermediate cells. So based on these 3 criteria, it's divided into low grade, intermediate grade, and high grade. So this is how the grading goes on. I have simplified and put it to a tabular column. So based on the cystic spaces, as you go higher, so you have 3 grades: low, intermediate, high grade. As you go higher, you get more of solid sheets. So more number of cysts are present within a low grade tumor. So as you go higher, the number of cyst-like areas decreases and you get more of solid sheets. The cells again, low grade, more of mucus cells. As you go higher, it becomes more of epidermoid and intermediate cells with less number of mucus cells. Pleomorphism, again, as you go higher, the number of pleomorphism or the pleomorphism becomes really, really higher. So it becomes marked nuclear pleomorphism with prominent nucleoli. Number of mitotic figures, atypical mitotic figures. Again, as you go higher, high grade will have frequent mitosis. Inflammatory infiltrate. This is the other way around. Inflammatory infiltrate will be common for a low-grade tumor. You can have extravasation of the mucin because mucin is more common to a low-grade tumor. So obviously that is going to evoke an inflammatory change. So inflammatory change is seen for a low-grade tumor. Less amount of inflammation will be present for a high-grade tumor. And another thing which you have to highlight in your answer is presence of necrosis and perineural invasion. Remember, adenoid cystic carcinoma, you have perineural invasion, and high-grade mucoepidermoid carcinoma will also show perineural invasion. Treatment, like always, it is surgical excision. So here treatment prognosis is going to depend on location, the grade, and the stage of the tumor. So surgical excision is what you have to do. Again, prognosis, good prognosis is better. The prognosis is better for low grade and minor salivary glands, and it's going to be bad for your high grade and submandibular gland. There is a variant for mucoepidermoid carcinoma. Now, when they ask you mucoepidermoid carcinoma as a whole, try to mention this variant there. It is called as intraosseous mucoepidermoid carcinoma or central mucoepidermoid carcinoma. So from the word intraosseous, you know that the mucoepidermoid carcinoma is going to occur inside the bone. That is why it is called as intraosseous or it's called as central. Usually mucoepidermoid carcinoma is the one which you see within the salivary gland. Now here you can see inside the bone. It is very, very rare. Now what could be the reason that you can get mucoepidermoid carcinoma within the bone? So the most common possibility is from the odontogenic epithelium, especially your dentigerous cyst, because dentigerous cyst, remember, they have mucus cells within the lining. So from there, long-standing dentigerous cyst can get converted to mucoepidermoid carcinoma. So the most common source for the presence of mucoepidermoid carcinoma within the bone is your odontogenic epithelium, especially the lining epithelium of dentigerous cyst, because it contains mucus cells. Then it can arise in the maxilla. So if it arises in the maxilla, the most common possibility is your sinus lining. Most common site for occurrence of intraosseous is in the mandible. Now, when you take an X-ray, since inside it is present inside the bone, you have to take an X-ray. So when you look at the radiograph, it's going to be either a unilocular presentation or a multilocular radiolucency, like you see here in this picture. And if it is associated with an unerupted teeth, you have to have other differential diagnosis also, especially all your odontogenic cyst. Histopathology is going to be same as mucoepidermoid carcinoma, and it's going to be as a low-grade nature. Non-neoplastic diseases, what you have to see is Sjogren's syndrome, necrotizing xylometaplasia, and xerostomia. The other thing which you have to look is adenitis and adenosis. So again, Sjogren's can be an essay or a short note. It is an immune-mediated diseases. And remember in this, it is lymphocyte-mediated destruction of exocrine glands leading to xerostomia and keratoconjunctivitis. So here you have two common things which is going to happen: dryness of mouth with dryness of your eyes. Again, you have a lot of etiological factors. Common to the females, age group is above 40 years. You have to keep the triad in mind. You have dryness of the eyes, dryness of the mouth, and you have rheumatoid arthritis. There are two types here, primary and secondary. So primary is just associated with the main symptoms, while secondary is associated with your connective tissue, immune-mediated diseases, that is rheumatoid arthritis and scleroderma. Again, as I've already told you, it is dryness of both your eyes and mouth. You can have a burning sensation, reduction in salivary flow rate, lymph node enlargement, If it is dryness in the eyes, you get a scratchy, gritty sensation and blurring of vision. Radiographically, you have to remember this. That is cherry blossom or branchless fruit-laden tree appearance. So this is what you get on a xylography. Diagnostic criteria, you have to keep in mind, that is called as a San Diego criteria, that is ocular dryness. Here you do two tests, that is Schimmer's test, that is you keep a litmus paper, and if it is less than 8 mm of wetting per 5 minutes, then you have to think of Sjogren's. And you have to do a staining. If you get a pink color stain within the conjunctiva, it demonstrates keratoconjunctivitis. The other test which you have to do is a lip biopsy. Now, within a biopsy, you have to count the number of lymphocytes. So if it is 50 lymphocytes per 4 mm square of the tissue, and if you have, so this is one foci. So focus, if you have more than one focus, you have to think of positive Sjogren's syndrome. Then you check for the salivary flow rate. The other findings on serology or on blood, you have to rule out rheumatoid factor. You have to rule out anti-nuclear antibodies, that is anti-SSA, anti-SSB and all. And also the IgA, ESR is going to be elevated. Histology, what you're going to get, remember it is lymphocyte-mediated destruction of the salivary gland. The lymphocytes are going to destroy your salivary gland. So it will replace the entire, it will destroy the entire acini, and only the architecture will be maintained. You can have proliferation of the ducts, which will give rise to something called as the epimyoepithelial islands. The ducts will proliferate along with the myoepithelial cells. So you can get something called as the epimyoepithelial islands. So entire gland will be destroyed, but the architectural outline will be present. Treatment, what you have to do is a symptomatic treatment. And remember, again, rare, it can undergo malignant transformation to lymphoma. The other thing which you have to remember is necrotizing xylometaplasia. Now, this is a non-neoplastic inflammatory condition of salivary glands. It is mainly because of infarction. Now, here, one thing which you have to remember is clinical presentation, histopathological presentation can simulate your squamous cell carcinoma, or it can simulate other malignancies. So you have to have other differential diagnosis here. Age group, older age group. This is common to males. It can be unilateral or bilateral presentation. Most common site of presentation is palate. So especially in the posterior area of the palate, you can get a swelling. And what happens is you get ulceration. That is a cratiform ulcer-like presentation will be there, wherein you have to think of a malignancy. Even erosion of the bone can occur. So this is a way you get your necrotizing xylometaplasia because of ischemia. The ischemia can be produced because of certain reasons like this. And finally, you will get infarction, necrosis. And along with that, you can have squamous metaplasia happening. Okay, so that is why it is called as necrotizing xylometaplasia. There is metaplasia of the ductal elements into squamous. So histopathology, what you're going to see is coagulative necrosis, necrotizing xylometaplasia. So you will see necrosis. Along with that, you will see squamous metaplasia. You can see mucin pooling. You can see a lot of inflammatory infiltrate. Hyperplasia of the overlying epithelium. Now, when you see like this, you have to think of squamous cell carcinoma. One shot, when you look at the histopathology, it will resemble your squamous cell carcinoma. But unfortunately, basically, you don't tend to see any kind of dysplastic features. So that is a way to differentiate histologically. You don't see dysplastic features within this disease. Now, treatment, you don't need any treatment. Okay, so it will resolve by itself. No treatment is necessary and prognosis is going to be excellent. The other question, what is important for you is xerostomia. You know what it is. It is dry mouth. It could be a symptom of other disease, very common to older age group. Now, what happens when you look at the clinical features? There'll be a reduction in the saliva. You have dryness of the mouth, dryness of the lips, papillary of the tongue. You can have secondary fungal infections, difficulty in speech. So these are the clinical manifestations you can get related to xerostomia. This is what is important from your exam point of view, the causes of xerostomia. You can have temporary causes, you can have permanent causes. So temporary causes is because of some stress. It could be presence of a calculi or a stone within the duct, infection of the salivary gland, certain drugs can produce xerostomia, and tobacco and alcohol. The permanent causes will be like your Sjogren's syndrome and your other systemic disorders, including ionizing radiation. So this covers your entire disease of salivary gland. These are the questions which was asked for the past KUHAS question papers. This is taken from the KUHAS question papers. Now, if you observe, these are the questions which is frequently asked. You have adenoid, you have pleomorphic, mucoepidermoid, Sjogren's, xerostomia. So these are the questions which has been repeatedly asked over the past few years. And this is a format to write your answer. So I've put pleomorphic adenoma as a way to write your answer. You should carry all the points with representation, wherever you can represent as a flow chart, wherever you can represent it with the diagram, try to do it. So this is a way to attempt the answer with all the subheadings. Thank you and have a good day.
Thank you so much, Priya ma'am. That was an accolade students teaching style indeed. That was a wonderful presentation. It was really exam oriented. Thank you for the wonderful presentation. Happy learning, children. You've got wonderful faculty in here. Thank you, ma'am. Thank you, Dr. Nidhi. Moving on. Up next is a very relevant topic, and we have diseases of the bone to be discussed in two different segments handled by two speakers. The first segment of which is to be rendered by Dr. Rakesh S. And Sir is the Vice Principal of Amrita School of Dentistry and is also the Head of the Department, Oral Pathology and Microbiology, Amrita School of Dentistry. And he's the Assistant Controller of Examination, Amrita Vishwavidyapeetham. He is also the member of Board of Studies, Amrita Vishwavidyapeetham. He is the External Examiner for BDS, MDS, and PhD to various health universities. Also has presented various scientific papers at numerous national and international conferences with 30 scientific papers published in index journals. I wholeheartedly welcome Dr. Rakesh S., our esteemed speaker for the next session. Over to you, sir.
Thank you for those words of introduction. I hope I'm audible.
Yes, sir, you're audible.
Yeah, thank you. So very good afternoon, children. At the onset, I would like to thank Dr. Deepu and his entire team for having come up with this novel venture. I think we have not had this type of a UG interaction before. This is the first time the undergraduates are getting an academic treat as to how to prepare oral pathology for their exam point of view. So I'm sure the students will take the best advantage of this. And I'm indeed honored to be a faculty giving a lecture on this prestigious platform. So with these words, let me just take a minute and share my screen. Please let me know if this is visible to you.
Sure, sir.
Yeah, thank you. Thank you. So I bring you greetings from Amrita School of Dentistry, which is a constituent of...
With your permission, sir, it's just starting to screen share. Shall we wait for a moment?
Yeah. Please. I'll just wait for that.
Please put on the PowerPoint view, then we'll be fine.
I've just put it on presentation mode. I think it will be coming now.
Okay, sir. Okay.
Hope it's visible now.
Yes, sir.
Yeah,
Perfect.
thank you.
Okay.
So greetings from Amrita School of Dentistry. We are part of Amrita Vishwavidyapeetham University based at Coimbatore. And in the next 1 hour, I'll be dealing with the topic which is allotted to me, diseases of bones. As was mentioned in the introduction, diseases of bones is being dealt with by two faculty members, myself and Dr. Jubin, who will be continuing after my talk. So to start with, this is one of the very common essays which you can get in diseases of bones. So let me just take you back to my undergraduate days when I was reading Schaefer and preparing for exams. When you come to this particular topic, the diseases of bones, one query which usually had come into my mind, what all diseases should you include in this chapter? Because if you see, there are a lot of diseases which are affecting the jaw bones. You have odontogenic cysts which occur in the jaws. You have odontogenic tumors which occur in the jaws. You have a lot of other reactive lesions which occur in the jaws, plus neoplastic lesions. So which group of diseases would you strictly say as occurring in the bones, as diseases of bones? If you remember this particular point, that in this chapter, we are going to deal with diseases which primarily originate from the bone tissue. So either an osteoblast or an osteoclast, that is the bone forming cell or the bone resorbing cell, has to have a role in the pathogenesis of this particular disease. Only then you can call that particular disease as a disease of bone. So only such diseases where these cells are directly involved in the pathogenesis of the disease, we are going to include under diseases of bones. So the usual essay question which is asked is classify diseases of bones. This will be the first part of the essay. It is true for most of the topics. Enumerate or classify or enlist. This will be list. This will be the first part of the essay. So in bone, you will get the first part as classify diseases of bones, enumerate the pathologies affecting the bones, or list the various diseases affecting the maxilla and mandible. So all these mean the same thing. You have to just list out or classify the diseases of bone. So that is what I'm going to deal with first. So to make your classification very easy, now most of our standard textbooks have just listed bone diseases randomly. They have not followed any particular classification, unlike for odontogenic cyst or odontogenic tumors or salivary gland pathology, where you have a WHO classification which is set and we just need to follow that. Now, unlike that, for diseases of bones, which are especially affecting the jaws, we don't have a standard classification. So it is always good to make our own working classification to include all the diseases, to group them under certain headings so that it becomes easy for us to remember. So I have just grouped them under 4 broad headings, very easy to remember. The first group being, as you know, hereditary, genetic, or familial. The second group, neoplastic. All neoplasms, the true neoplasms will come under this category. The third group, idiopathic. Idiopathic means without any specific cause. You still don't know what actually causes this particular disease. So such diseases you can group under idiopathic. And the last group is fibroosseous. So this is one particular group of bone disorders, the bone pathologies, which requires a special discussion. So this group is what I will be dealing with in my first part of bone disorders. The rest of it will be dealt by Dr. Jubin in the next lecture. So moving on to the entities which you can enlist under each of these headings, under familial, hereditary, or genetic. These are the bone diseases which you should write under. Osteogenesis imperfecta, marble bone disease or osteopetrosis, craniosynostosis syndromes. Now, these are a group of syndromes involving the fusion of cranial bones. The craniofacial dysostosis or Cruson syndrome and the Apert syndrome. You will all be familiar by now with these 2 syndromes because you have beautiful pictures given in your textbook. So if you remember those pictures, you will be able to write the manifestations of these syndromes. Then you have cleidocranial dysplasia, whereby the most prominent feature is the hypodeveloped or absence of clavicle or the collarbone, thereby leading to hypermobility of the shoulder joint. The affected individuals can bring their shoulders up to the midline. And then Marfan syndrome. Now, Marfan syndrome again is a multisystemic syndrome, but mainly affecting the bones. So these are the group of diseases which you should include under hereditary or genetic bone diseases. Then coming to neoplastic. These are what are grouped under neoplasms. Osteoma, osteoid osteoma, osteoblastoma. These three will always come together. Even in your textbook, they are mentioned one after the other. It is easy to study the features because you can compare and study. Then coming to giant cell tumor of bone, which is also called osteoclastoma. And then the malignant tumor arising from the bone tissue, that is osteogenic sarcoma or osteosarcoma. Now you have idiopathic diseases, diseases where the etiology is still not known. Some people believe that the Paget's disease or osteitis deformans is a metabolic disease. Some others believe that it is a reactive phenomenon. But the truth is, so far, nobody knows what exactly causes Paget's disease. Then you have Langerhans cells histiocytosis. Now, this is a spectrum of bone diseases whereby you have at one end of the spectrum, the comparatively better prognosis eosinophilic granuloma, whereas in the opposite end of the spectrum, you have the Hand-Schuller-Christian disease. And intermediate, you have the Litera-CV disease. So these are the different group of bone diseases which come under idiopathic. Now coming to my topic, what I'm going to discuss, the last group, the broad heading of bone diseases which I mentioned was fibro-osseous lesions. So fibro-osseous lesions, it is always good to follow two classifications. One is the standard classification which is given in your textbook, Waldron's classification, which was given by Waldron in 1993. See, Waldron is a name which you can remember because he is to fibro-osseous lesions like G.V. Black is to caries. So Waldron was the pioneer who did a lot of work on fibro-osseous lesions. So this was the classification which Waldron gave, and it's quite impressive because it's easy for you to remember. He grouped them under three broad headings: developmental, neoplastic, and reactive. Under developmental, you have the fibrous dysplasia. Under neoplastic, you have cemento-ossifying fibroma, and under reactive, you have cemento-osseous dysplasias. So this is the standard traditional Waldron's classification. I am also giving you a working classification because there are one or two lesions which are not included by Waldron in his classification which he had given earlier. So there is a fourth type which is added more recently, and that is the familial type, the gigantiform cementoma and cherubism. Now cherubism, when I come to cherubism, I will explain in detail. Traditionally, it was not considered as a fibro-osseous lesion. It was just considered as a bone disease. But then later on, some people gave it a term as familial fibrous dysplasia. So the moment you give it as a familial fibrous dysplasia, it becomes a fibro-osseous lesion because fibrous dysplasia is very much a fibro-osseous lesion. So still that term familial fibrous dysplasia stays for cherubism, though modern concepts state that it is completely different from fibrous dysplasia. But still, since the textbook mentions it as a familial form of fibrous dysplasia, we need to include it under fibro-osseous lesions and learn it like it is given in your textbook. So the developmental, neoplastic, and reactive are exactly the same as in Waldron's classification. We have just added familial subheading here. Now, the developmental fibro-osseous lesion is fibrous dysplasia. There are three subgroups which are given under the developmental fibrous dysplasia. One is the monostotic fibrous dysplasia. The other is the polyostotic fibrous dysplasia. This is based on the number of bones involved. If just one bone is involved, you call it monostotic. If there are more than one, if there is more than one bone involved, you call it polyostotic. Craniofacial fibrous dysplasia is a term wherein only the bones in the cranium, the skull, are involved. It may be just one bone or many bones. But even if more than one bone of the cranium is involved, craniofacial fibrous dysplasia is grouped under monostotic fibrous dysplasia because cranium as such is taken as one unit. So if you look at your textbook, they have included craniofacial fibrous dysplasia under monostotic fibrous dysplasia. It's only that when the fibrous dysplasia is restricted to the cranial bones or the bones of the skull, whether one or multiple, it is called craniofacial fibrous dysplasia. The neoplastic one is central ossifying fibroma. Earlier, it was known as ossifying fibroma or cemento-ossifying fibroma. If you follow the earlier editions of Schaefer, you will come across these other terms which were very prevalent earlier. Ossifying fibroma, cemento-ossifying fibroma. All these were used one for the other to denote this particular entity. But now, if you look at the present textbook, WHO is very clear that cemento-ossifying fibroma is a odontogenic lesion. It is not coming under bone pathology. It is an odontogenic lesion. It is a neoplasm of odontogenic origin. So WHO has clearly segregated these two entities now. The central ossifying fibroma is the bone neoplasm and is included under fibroosseous lesions. That is neoplastic, affecting the bone. The central cementifying fibroma is an odontogenic neoplasm, neoplasm of odontogenic origin. But the features, both clinical, radiographic, as well as histopathologic, almost remain the same, with a minor difference in the nature of calcified tissue. If you have bone-like trabeculae, then you call it central ossifying fibroma. If you have cementum-like globules, you call it central cementifying fibroma. That is the difference. But all the same, since the tissues are different, one is bone, the other is cementum-like, WHO has clearly segregated it, one as a bone neoplasm, the other as a odontogenic neoplasm. The third is the reactive fibroosseous lesion, cemento-osseous dysplasias. They were earlier just called as osseous dysplasias. You have three types of cemento-osseous dysplasias: the periapical, focal, and florid. We will come to that a little later. So we will just see what are the differences between each type. And of all the fibroosseous lesions, these are the most common. But unfortunately, they are usually not discovered routinely because they are usually asymptomatic. So their incidence reported is very less. But by far, they are the most common of all the fibroosseous lesions. And the familial ones are gigantiform cementoma and cherubism. Out of this, cherubism is of special interest to us because it is a genetic disease affecting the jaw bones in children and designated as familial fibrous dysplasia of the jaws. But as per recent genetic studies, it is an entity which is quite distinct from fibrous dysplasia, and it has to be dealt with separately. So before we go on to individual fibroosseous lesions, we should know the mechanism, pathogenesis, why fibroosseous lesions are called by that name. See, they are bone pathologies. Then why do you have to categorize them as fibroosseous lesions, unlike other bone pathologies? Because what happens here is normal bone tissue is replaced by cellular fibrous connective tissue. Unlike in other bone pathologies, in a fibroosseous lesion, your basic bone tissue gets replaced by cellular fibrous connective tissue because of some derangement in the mechanism, either in osteoblastic or osteoclastic mechanisms. That is what happens basically in a fibroosseous lesion. So when the bone gets replaced by fibrous connective tissue, you will see the changes on the radiograph also. Usually bone being mineralized is radio-opaque on the X-ray. When it gets replaced by fibrous connective tissue, that is a soft tissue. So what happens to its radiographic appearance? the opaque appearance becomes loosened. The bone trabeculae, they start losing their mineral and they start replacing by fibrous connective tissue. So as the time progresses, this replaced connective tissue starts producing mineralized component. It starts undergoing metaplasia. You know what is metaplasia? Functional transformation of one tissue into another tissue. That is what you call metaplasia. So the fibrous connective tissue which has replaced normal bone, as time progresses, will start producing metaplastic bone or cemented, calcified tissue. So if you take the radiographic picture of fibroosseous lesions, it will depend upon the stage at which you have taken the radiograph. If you take the radiograph in the initial stage, where normal bone is being replaced by fibrous tissue, you will get the lesion as totally radiolucent because the entire bone has been replaced by a fibrous tissue. It starts getting destroyed and it starts getting replaced by fibrous tissue. So that part with that lesion will be radiolucent. If you take the radiograph when the lesion is somewhat in the middle stage, then you will get a mixed picture because after completely forming, destroying bone, that is after the bone is entirely replaced by fibrous tissue, the fibrous tissue starts producing metaplastic bone. So here and there, you will get calcified structures. So it will be a mixed radiolucent radiopaque picture. And if you take the radiograph in the last stage, after a prolonged stage of the disease, then you will completely find it radiopaque because by then this fibrous connective tissue would have formed a lot of metaplastic bone or cemented. So the radiographic image appearance will depend upon the stage at which the image is taken. So it is easy for all fibroosseous lesions, one of these pictures will be there depending upon the stage at which you have taken. This is a diagrammatic representation. See, here you have the normal bone. You can see the normal bone trabeculae with marrow tissue. You can see the osteocytes. The osteoblasts are lining the bone tissue and osteocytes are inside. This is normal bone. But what happens in a fibroosseous lesion? This bone tissue also gets replaced by fibrous tissue. So the marrow and the bone becomes fibrous. The entire tissue becomes fibrous. So as this time progresses, what happens inside this fibrous tissue? You start getting metaplastic bone. The fibrous tissue produces metaplastic bone. So that is what happens in fibroosseous lesion. Normal bone gets replaced by fibrous tissue. Gradually, this fibrous tissue produces metaplastic bone tissue. It can be either bone or cementum-like material. So there is only one expected essay question after scanning your previous question papers. From fibroosseous lesions, only one expected essay you need to prepare. Enumerate the various fibroosseous lesions. As I said, the first part of the essay is usually that. Discuss the etiopathogenesis, clinical, radiographic, and histopathologic features of fibrous dysplasia of the jaws. Usually, in many universities, the usual essay question from fibroosseous is fibrous dysplasia. So we will see how to approach this. You have to plan because you cannot sit there and start thinking what you will write. If you have an idea before, after referring previous question papers, you have prepared, if fibrous dysplasia comes as an essay, I have to write all this. If you have that picture in your mind, it becomes easy for you to write that for your theory exam when it is asked. It is much easier than seeing the question for the first time. Then you will have to sit and spend 5 or 10 minutes thinking of what to write. So that is the greatest advantage you are having with this exam tips class. You are actually getting, for all the chapters, what to write, what to include in each essay or short note. So try to make use of that. Try to collect all this material and read it before you go for your theory exams. So suppose you get a fibrous dysplasia as an essay question. The first part is fine. We have already enumerated the various fibroosseous lesions. We have written Waldron's classification. We have also written the working classification, including familial fibrous dysplasia, and that is cherubism, and gigantiform cementoma. That is over. Now coming to the second and main part of the essay. You can split it into the following parts and include these parts under these subheadings. Definition or a brief introduction about fibrous dysplasia. That is very, very important. Don't just start writing etiology. If etiopathogenesis is the first thing which is asked, don't write etiology of fibrous dysplasia. No, that is the biggest mistake you make. You write 1 or 2 lines about what is fibrous dysplasia. That is what you should do first. Then start answering. Then etiology and pathogenesis, clinical features. For most of our oral pathology lesions, we will have to write about oral manifestations. In some diseases, instead of clinical features, you can directly write oral manifestations because they may not appear elsewhere in the body. So in such cases, you directly write oral manifestations. Then radiographic features, histopathologic features, followed by management. So let us see what to write in the definition or a brief introduction about fibrous dysplasia. Things what you already know about fibrous dysplasia, you can just highlight 2 or 3 points here. It is a developmental fibroosseous lesion. It is non-hereditary. Of course, an anomaly affecting the bone. You are studying this under bone diseases. And what happens here? There is a defect in the differentiation and maturation of osteoblast. See, I told you, under bone diseases, we are including only those diseases which primarily originate from the bone tissue or where osteoblasts or osteoclasts are directly involved in the pathogenesis. Only those diseases we are including under bone diseases or bone pathology. So a developmental disease, non-hereditary, affecting the bone, where you have a defect in the differentiation and maturation of osteoblast. You can write one more point. Why you call it a fibroosseous lesion? Because here there is replacement of bone tissue by fibrous connective tissue followed by metaplastic bone formation. So that is basically what a fibroosseous lesion is. So these 3 points you can include under your introduction of fibrous dysplasia when you write your essay. Now you can also get fibrous dysplasia as a short note, a 4 or 5 mark question. Now in that you can just make it more brief. You just write fibrous dysplasia is a developmental non-hereditary fibroosseous lesion where there is a defect in the differentiation and maturation of osteoblast. That's a fibroosseous lesion. You don't need to explain further. Then go to the etiology and pathogenesis. So when you write essay, you have to be a little elaborative. So now we know from you, it is given in your textbook, though the exact cause is unknown, the present concept states that it is because of genetic mutation. Mutation in the NAS1 gene located on chromosome 20. So what does this NAS1 gene do? It encodes for the G protein, which is involved in the production of CAM in many tissues, endocrine, melanocyte, osteoblast maturation, etc. It is very important because, see, you don't need to mug up clinical features or histopath features. If you apply your mind, you will get all these features within that topic. You just need to correlate. Now look at this particular sentence. The G protein is involved in the production of CAM in many tissues like endocrine, melanocyte, osteoblast maturation, etc. All these tissues are involved in the clinical features of fibrous dysplasia. You know, endocrine disturbances, cafe au lait pigmentation on the skin. It is basically a defect in the maturation of osteoblast. So now you get the correlation. How do all these manifestations come? Because of this problem. So that is how you should correlate instead of just blindly, mugging up and then trying to recollect. You will not remember much. So connect this to the clinical features. So let us see what happens. The NAS1 gene mutation leads to a continuous activation of the G protein. So it keeps on activating this G protein. So what happens? There is overproduction of CAM and there is abnormal function in the tissues. Which all tissues? Endocrine, melanocytes, osteoblasts, etc. So the whole thing will be either hypo or hyperfunctioning. There will be abnormal functioning. Okay. This activated G protein also affects the Wnt-catenin signaling pathway, which is required for the remodeling, bone remodeling. So all these are likely to get affected. The endocrine function, bone remodeling, melanocyte activity, all these will get affected in fibrous dysplasia. The primary defect is in osteoblast. The first primary tissue which gets affected is the osteoblast or bone tissue. So now let us move on to the clinical features or oral manifestations. So you have to first write about the types of fibrous dysplasia. Based on the severity of the disease and number of bones involved, you have monostotic fibrous dysplasia and polyostotic fibrous dysplasia. As I said earlier, one form of monostotic fibrous dysplasia is the craniofacial fibrous dysplasia, where only the disease is restricted to the cranium or the skull. The common manifestations of fibrous dysplasia, whether it is any form, polyostotic or monostotic, will appear between 3 to 15 years of age. So when the child is around 3 years of age, after that, the manifestation starts appearing. There is no race predilection, there is no sex predilection, though people say there are some books which say that there is a slight female predilection, but many studies have proved that there is no sex predilection. It affects both males and females equally. And the mechanisms are same. Bone is replaced by fibrous tissue. So first coming to polyostotic fibrous dysplasia. Here more than one bone will be involved. And it forms around 20 to 30% of all the fibrous dysplasias. It usually affects the long bones, femur, tibia, the pelvic bones, ribs. All these are the bones which are primarily affected. They can also affect facial bones, especially the skull bones. And in skull bones, it is said that there is a marked propensity to occur in the maxilla in children. When it occurs in maxilla in children, it can be a little aggressive. The growth can be a little aggressive. So this is a comparison. Always, wherever possible, try to compare and learn. If you learn monostotic separately and polyostotic separately, fine, no problem. But always compare. Only then you will know the difference. Otherwise, you will keep mugging up whatever comes under monostotic. You will keep mugging up whatever comes under polyostotic. Ultimately, will not remember many points. So always compare so that the point can be the same and the differences you can mark. The number of bones involved. In monostotic, only one bone is involved. In polyostotic, more than one bone is involved. Monostotic, 70 to 80% of fibrous dysplasias come under this category. So, which is the more prevalent form? It is the monostotic form. Polyostotic, it is more severe, but it forms only 20 to 30% of fibrous dysplasias. In monostotic, it affects ribs, tibia, and the craniofacial bones mainly. Whereas polyostotic, the long bones and the ribs, pelvis, and facial bones. So there is a little difference. Ribs are more affected in monostotic. Long bones are more affected in polyostotic. But in both cases, craniofacial bones can be affected. It's more affected in monostotic, 10 to 25%. Now in monostotic, since only one bone is affected, there is no association with other abnormalities. Whereas in polyostotic, you have 3 syndromes, which you should remember. One is McCune-Albright syndrome, Jeffries type, and Massabrod syndrome. These are important. McCune-Albright syndrome can be asked for that short question. You have the 2 or 3 marks question. For that, you can get McCune-Albright syndrome. The other two, remember for Viva, what is McCune-Albright syndrome? What is Jeffy's type? What is Mesebrod syndrome? All these can be asked as Viva questions for you. So in polyostotic form, you can find all these manifestations. Monostotic, no other systemic manifestation. You can have craniofacial fibrous dysplasia where the cranium is affected. The skull bones are affected, but it's grouped under monostotic. Now let us see what is McCune-Albright syndrome. McCune-Albright syndrome is the association of polyostotic fibrous dysplasia along with precocious puberty, cafe au lait spots, and other endocrine abnormalities. Remember this triad. Polyostotic fibrous dysplasia, precocious puberty and other endocrine abnormalities, cafe au lait spots. The triad, 3 features. That is what is included under McCune-Albright syndrome. Here, basically, there is a hyperactivity of various endocrine glands. See, I told you, the NAS1, the G protein, ECAMP, all that is linked to the functioning of melanocytes, endocrine, and osteoblasts. So, all the 3 are affected here. You have fibrous dysplasia, whereby the osteoblastic activity is altered. Precocious puberty and endocrine abnormalities because the endocrine system is activated. Cafe au lait spots because the melanocytes are activated. So if you link the etiology with the clinical features, it becomes easy for you to remember. So you should know something about cafe au lait spots. Again, a short answer question. The 2 marks or 3 marks question, short note you can have for cafe au lait spots. So what is cafe au lait spots? Cutaneous pigmentations which are found in polyostotic fibrous dysplasia. Now, this I am telling you with the context of polyostotic fibrous dysplasia. It is also found in neurofibromatosis. So if you are writing a general short note on cafe au lait spots, you have to mention that also. Cutaneous pigmentations found both in polyostotic fibrous dysplasia as well as neurofibromatosis or von Recklinghausen's disease of skin. Now, what are they basically? They are macules. Macules are flat pigmented lesions which occur on the skin. Why are they called cafe au lait? Because coffee with milk or cream, brown with white. Brown pigmented macules with white spots. That's how the cafe au lait spots appear. Why do they occur? Linked again to NAS1 mutation, G protein activation and all that. Increased melanocytic activity in the basal layer of the skin. Usually this is found on the skin of the patients affected with polyostotic fibrous dysplasia. Intraorally, it usually doesn't occur. It usually occurs more on the cutis or the skin. There is a peculiar pattern in fibrous dysplasia. Cafe au lait pigmentation in fibrous dysplasia. It's linear arrangement. That means in a straight line, multiple patches will be there in a straight line or segmental arrangement near the midline of the body. It will be more closer to the midline. The macules have corrugated or ragged border. So that resembles the coastline of Maine. So let us now compare. This is again for your short note. When you are asked short note on cafe au lait spots, you can include this. You can compare the cafe au lait spots in fibrous dysplasia with the cafe au lait spots in neurofibromatosis, because when you are asked cafe au lait spots, you have to write something regarding cafe au lait spots, not regarding fibrous dysplasia or regarding neurofibromatosis. So in fibrous dysplasia, the cafe au lait spots are skin macules which are variable in number. They can vary from 1 to some multiple number. There is no upper limit. Whereas in neurofibromatosis, they are 6 or more in number, minimum 6 you will find all over the body. In fibrous dysplasia, cafe au lait spots may be present at birth or may manifest after 3 years. But in cafe au lait spots, usually they are present at birth. Their size increases after puberty. After the patient reaches puberty, their size will increase. In fibrous dysplasia, you will have them brown with white. Even in neurofibromatosis, it will be brown with white. That is why you call it cafe au lait spots. Areas near the midline of the body, that is where you find fibrous dysplasia cafe au lait spots. In neurofibromatosis, you have a general distribution on the skin, on the trunk, may occur on the facial skin also. In fibrous dysplasia, the cafe au lait spots have ragged borders. The lesions have ragged borders. They resemble the coastline of Maine. Whereas for neurofibromatosis, the cafe au lait spots have smooth borders. So they resemble the coastline of California. So here you can see this is cafe au lait pigmentation in fibrous dysplasia. See the ragged borders here. You can see the ragged borders, not smooth. And this is the coastline of Maine. See, this is Maine is a province in the United States of America on the Atlantic coast. So you can see that the coastal outline of Maine is also ragged. Whereas the cafe au lait spots in neurofibromatosis, it is smooth. The borders are smooth. And it resembles the coastline of California. California is again on the opposite coast, the Pacific coast of the United States. So you will find that the coastline is smooth. This can be asked for your viva. Examiners are very fond of asking you, what is the difference between cafe au lait spots in fibrous dysplasia and neurofibromatosis? Then they will ask you, which one resembles coastline of Maine and which one resembles coastline of California? So just remember this. So that is regarding McCune-Albright syndrome. What is Jeff's disease? Jeff's disease is association of polyostotic fibrous dysplasia with cafe au lait spots only. There are no endocrine abnormalities here. So only the osteoblast and melanocyte activities are altered. Endocrine tissues are not involved here. So that is Jeff's disease, Jeffy's disease. And the last one in polyostotic fibrous dysplasia is, it's comparatively rare when you compare McCune-Albright and Jeff's disease, Massey-Broad syndrome. Here you get polyostotic fibrous dysplasia along with intramuscular myxomas. Myxomas are connective tissue tumors, neoplasms. It accounts for only 1% of fibrous dysplasias, occurs more in ladies, women, and both lesions occur in the same anatomic region. So if fibrous dysplasia affects the maxilla, even the myxomas will affect the facial region. If fibrous dysplasia affects the tibia, even myxomas will appear in the same region. So that peculiarity you can find in Massey-Broad syndrome. Another special thing what you need to remember about Massey-Broad syndrome is the percentage of Massey-Broad syndrome where fibrous dysplasia transforms into malignancy is more when you compare with other forms of fibrous dysplasias. That is another peculiarity which you should remember. Now coming to the next part of the essay, clinical features are over. Oral manifestations, that is what we should include more. This is common for both polyostotic and monostotic. The only difference being number of bones involved. In monostotic, only one bone will be involved, and that will be the jaw bone when there is oral manifestation. In polyostotic, along with jaw bones, you can have other long bones also involved. That is the only difference. Oral manifestations remain the same. What is the initial manifestation? Pain, swelling, and deformity of the affected jaw. That is the initial symptom or clinical manifestation. There is a painless bulge on the affected part of the jaw. First clinical sign. So what does it lead to? When you have a enlargement of that part of the maxilla or mandible, you have malalignment and displacement of the teeth. Gradually, that area becomes tender. In the later stages, upon palpation, you will have tenderness. Endocrine disturbances will lead to delayed eruption, altered eruption, etc. So the eruption sequence can be altered depending on if it is polyostatic, you will have endocrine disturbances that can affect the eruption sequence. So usually small children are affected, and in many cases it is seen that maxilla is affected. The swelling is not well circumscribed. That is how you differentiate a swelling of fibrous dysplasia from a swelling in ossifying fibroma. In ossifying fibroma, it is well circumscribed, whereas in fibrous dysplasia, it is diffuse. It blends with the surrounding bone. You cannot differentiate it from the borders from the surrounding bone. And as it progresses, it can extend to involve the maxillary sinus, the orbital floor, and zygoma. So in the affected area, you can have a diffuse swelling involving the maxilla in that region. So in the later stages, the patient can go in for severe malocclusion, a prominent canine fossa, and marked facial deformity. That's what usually happens in the later stages. See this here. I hope you are able to appreciate the swelling on the right side. You can see a diffuse swelling when you compare with the left side. And you can see that it is diffuse. The borders you cannot differentiate. It's blending with the surrounding normal bone. So this is affecting the maxilla, and I think it has already started involving the nasal, the maxillary sinus and the nasal antrum. What are the radiographic features? Since it is a bone disease, you definitely will have radiographic features. As I said, early lesions will show one feature, late lesions or mature lesions will show another feature, but it's almost the same for all. Early lesions usually appear as uni or multilocular radiolucent lesions because there is destruction, replacement of bone by the fibrous tissue. In mature stages, what happens? The radio-opaque foci start appearing within the radiolucencies because the fibrous tissue will start producing metaplastic bone. So there is a mixed appearance. This mixed appearance is often called ground glass or orange peel appearance. That is, there is an overall difference in the density of bone trabeculae. That smooth bony trabeculae will not be there. Since the bony trabeculae are replaced by fibrous tissue, the density of the trabeculae will start decreasing. And the bone which is being formed also will not be of the same density. So overall, there will be a ground glass or orange peel appearance. You should also remember for viva what is rimmed sign on the radiograph. The normal trabecular appearance of the bone is lost, and the radiolucent lesion will have a thick sclerotic border, a radio-opaque border. That is what is called the rimmed sign as the time progresses. Now I'll show you what is ground glass appearance. See the appearance here? That is what you call ground glass appearance. This is ground glass. The texture of ground glass is more opaque. The normal glass is transparent. You can see through, whereas the ground glass is opaque. You cannot see through the opposite side. That texture you will have for the bone affected with fibrous dysplasia. This is orange peel. See the peel of orange pattern? The same texture you will find for the appearance. So it's either called ground glass or orange peel pattern. Usually for viva, ground glass appearance is seen in which lesion? Suddenly you can be asked. Orange peel appearance is seen in which lesion? The periphery of the lucent lesion is always ill-defined because I told you the borders are diffuse. They will merge with the surrounding normal bone. You cannot differentiate the borders in a fibrous dysplasia. That is how you differentiate it from ossifying fibroma. Ossifying fibroma, always the borders will be well demarcated. So after radiograph, it is now the turn for histopathology. If you take a biopsy from the area and see the microscopic picture, what do you find? You will find characteristically many C-shaped trabeculae of woven bone. What is woven bone? Bone which is being formed. Immature bone is called woven bone. So C-shaped, curvy linear. They are not linear, they are curved as well as linear, short. They are not interconnected. So individual C-shaped trabeculae of woven bone. How is the stroma? Moderately cellular. It is fibrous. These trabeculae characteristically will not have the osteoblastic rimming. What is osteoblastic rimming? Where you find osteoblasts lining the bone trabeculae. Usually in normal bone, where bone formation is happening, osteoblasts will line the trabeculae of bone. But here, you will not have the characteristic limbing in most of the cases. In early lesions, you will have more of fibrous tissue. In advanced lesions, fibrous tissue will be less. You will have more of Chinese letter-shaped trabeculae, C-shaped or Chinese letter-shaped trabeculae. And the lesional bone will fuse, blend with the surrounding normal bone because the borders are not demarcated. That you can make out clinically, radiographically, and histopathologically. How clinically? A diffuse swelling without borders. How radiographically? You can see it as a diffuse swelling where it is fusing, the borders are fusing with the peripheral bone. And how histopathologically? If you look at the borders of the lesional tissue, the trabeculae will blend with the surrounding normal bone. So that you can see in all the three phases. This is the typical appearance of trabeculae in fibrous dysplasia. You can see the curvilinear trabeculae, see, C-shaped. This picture here shows the Chinese letters. See, they are also curved, some are linear, some are curved, some are both. So the same pattern you will have for the trabeculae of woven bone, which you find in fibrous dysplasia. So easy to draw. So you should also have the idea of drawing this picture when the essay comes. What is the management? There is no specific treatment which is required for monostotic fibrous dysplasia. It is self-limiting in most cases. The expansion of bone will stop once patient reaches puberty. In very rare cases, if the patient or the doctor feels it as a necessity, they go in for cosmetic surgeries, but it's usually not required. Where you require treatment is polyostotic fibrous dysplasia, not for the bone deformity, but for the associated systemic defects, because you have multiple bone defects, multiple bones may be involved, and endocrine problems also may be there. So a multidisciplinary approach is required, not just a dental treatment. Then you should also remember a faint, very, very slight possibility of malignant transformation of fibrous dysplasia into osteosarcoma, fibrosarcoma, etc. Now, that is very, very rare, but if at all it occurs, the chance is more in Massabrod syndrome. That is what your textbook mentions. So that has got more propensity to transform into malignancy, if at all there is a malignant change. Now, that completes the essay part. Now, let us see what are the expected short answer questions so that you can prepare accordingly. You have histopathology of fibrous dysplasia, which can be asked as a short note. You just need to write that particular portion, just the histopathology as well as the diagram, what we just gave you. Then you have McCune-Albright syndrome. That also I have covered. Whatever I discussed in McCune-Albright syndrome, you need to cover here. Then you have ossifying fibroma, cherubism, and osseous dysplasia. So I will just quickly go through that also. How do you differentiate writing an essay and writing a short note? For writing short note, you just need to write one or two opening lines about the topic which is asked and focus the rest of the answer specifically to the topic which is asked. Don't elaborate like you wrote in the X-ray. Let us see one example. Take the case of ossifying fibroma. Write what is ossifying fibroma. Write one or two lines about its etiology. In clinical features, don't mention other bones. Write more about oral manifestations. That is how you can reduce the matter. Write one or two lines about the radiographic appearance. Write specifically about the histopathologic features. and with a diagram. So diagram is very important, be it a short note or an essay, because histopathology, for oral pathology, it's more weightage given for histopathology. So wherever you would have a diagram, you write diagrams, you draw diagrams. So what is ossifying fibroma? It is a central neoplasm of the bone, now renamed as central ossifying fibroma. Though it is fibro-osseous, it is different from fibrous dysplasia and other reactive lesions because it is a neoplastic disease. It is a neoplasm. It shares similar features with central cementifying fibroma, which is now segregated by the WHO as a odontogenic tumor. Earlier, both were clubbed together as cemento-ossifying fibroma. Now they are segregated. What are the clinical and oral manifestations? It is usually a disease of the young adults, not children, young adults. Fibrous dysplasia, children. Ossifying fibroma, young adults. Both jaws are affected, predilection for mandible. Mandible is more affected. Fibrous dysplasia, equal predilection. Here, females are affected more. Fibrous dysplasia, no sex predilection. But there are some reports which say females may be affected. Initially, it is asymptomatic because it's very slow growing. It's not at all fast growing or aggressive. It is very slow growing, common in the posterior mandible. Mandible is more affected and it's common in the posterior mandible. So it becomes obvious or visible only in the later stages. Otherwise, it doesn't manifest itself. What are the radiographic features? Again, I'm repeating the difference from fibrous dysplasia. Ossifying fibroma is well circumscribed, well demarcated from the normal surrounding bone. Unilocular or multilocular. Usually it is unilocular. Very rarely it can be multilocular also. In the later stages, because it is asymptomatic initially, the patient may not be aware that the disease is progressing. So in the later stages, the appearance may become mixed because the bone tissue getting replaced by fibrous tissue and then forming more of bone tissue. And finally, in mature stage, radio-opaque. See the radiograph, you can see a well-demarcated unilocular radiolucency. This is somewhat in the mature stage because you can see that the radiolucency is filled with radio-opacity. So it is not the initial stage, it is almost a mature stage. It's quite a long-standing lesion. But see, in spite of being a long-standing lesion, see the size. It is well circumscribed and well demarcated. So that shows it is less aggressive when compared to fibrous dysplasia. Histopathology. You will have a highly cellular fibrous stroma. In fibrous dysplasia, the stroma is moderately cellular. Here it is highly cellular, and the stroma contains delicate collagen fibrils. The bony trabeculae are irregular. In the later stages, the trabeculae fuse and become interconnected. So that is what you find in the later stages. Treatment is usually conservative. You just need to excise. Very, very conservative excision will do. Usually it doesn't recur also. But the difference from fibrous dysplasia is that this is a neoplastic process. This is a neoplasm. See this? You can see this highly cellular connective tissue in the background with, you can see the trabeculae of bone. Along with that, you can also see woven bone, globules of woven bone. When this takes a hematoxyphilic appearance, that is when you say that they are cementum-like material. Usually cementum will take up a more hematoxyphilic appearance. So if that is the case, you have to segregate it as central cementifying fibroma. There you will not find more of trabeculae of bone. You will find more of cementum-like globules. Another group of fibro-osseous lesions which can be asked for your short notice, cemento-osseous dysplasias. This is again the same pattern can be followed for short note. What is cemento-osseous dysplasia? It's a group of reactive fibro-osseous lesions. It occurs in the tooth-bearing areas of the jaw. Usually in edentulous areas they do not occur. In the tooth-bearing areas only they will occur. And as I said earlier, they are the commonest fibro-osseous lesions, but not much reported because they don't manifest that easily. Asymptomatic initially. WHO has recognized 3 variants based on their features: focal, periapical, and florid. Again, actually what I will do is I will share this PowerPoint with Dr. Deepu. Those of you who want the PowerPoint can take it from Dr. Deepu. Because this chart, I don't think you will be able to take down everything now. You can refer later. Always learn such comparative charts that will make your learning very easy, rather than learning focal separately, periapical separately, and florid separately. Everything will get jumbled up. Learn this together. Clinical features, age or sex, middle-aged females, middle-aged females, middle-aged females. So it becomes easy. All usually affect middle-aged females. Lesions, usually single in focal, that's why you call it focal, multiple in periapical, multiple and multifocal in florid. Florid means more rampant, more areas are involved. So multiple and multifocal. Site, focal, mandibular molar region. Periapical, mandibular anterior region. Florid, posterior maxilla and mandible. Multifocal and multiple. So affect both maxilla as well as mandible, but in the posterior region. Exact location, focal in the periapical region. Periapical region of multiple teeth. Florid, posterior region of maxilla and mandible. Initial manifestation, focal, asymptomatic, it is usually a chance finding. Periapical, asymptomatic, chance finding. Florid, asymptomatic, later a dull pain can come. So again, easy. All are asymptomatic in the initial stages. Further course of disease, usually self-limiting, usually self-limiting. Again, very easy. Minor complications, if at all, can occur only in florid. Mostly all are self-limiting, don't require treatment at all. What are the radiographic features? All of them are diagnosed on routine radiographs because clinically, usually they don't present with any symptoms. And all of them occur in females, Black females. African population has got a remarkable propensity for the females to present with osseous dysplasias. They usually occur as well-defined radiolucency in the initial stage. Later stages, radio-opaque. Mature lesions are radio-opaque. Mixed appearance can also be seen in the middle stages, just like any other fibro-osseous lesion. A thin radiolucent rim may surround the lesion and will not fuse with they are all typically circumscribed. See here, this is focal cementosseous dysplasia. See, just a single lesion, focal lesion, but radio-opaque. So what is the stage? It is the end stage, mature stage. Multiple lesions here, see, in the periapical radiographs. So they are periapical cementosseous dysplasias, and they are in the initial stage. Here you can see, again, multifocal. Multiple quadrants are involved in both jaws. That is florid. So this is the radiographic picture. What will you find in the histopathology? Usually, biopsy is not taken because it's not needed. They are self-limiting. Radiograph itself will be enough to prove the diagnosis. But if at all biopsy is taken, you will find a very highly cellular connective tissue with many fibroblasts and collagen fibers. Stroma will show many globules of woven bone or cementum-like material. Numbers will depend on the stage of the lesion. If it is early lesion, these globules of calcification will be less. If it is late lesion or mature lesion, the globules will be more. These trabeculae in the late stages will resemble ginger root. You know what is a ginger root? I will show you that. See, this is what you call, inji, which we commonly use. This is very familiar to us. The trabeculae will resemble ginger root trabeculae. So this you can get for viva. Such appearances will come for viva. When suddenly they ask you, you can find it difficult. So if you already prepare and write and keep somewhere, it is easy. So ginger root trabeculae are usually characteristic of osseous, cemento-osseous dysplasias. The last topic, which I'm going to cover in fibro-osseous, is cherubism. Very often can come as short note. So what do you write in introduction? It is a genetic or familial disease of bone affecting children. Was considered as a familial form of fibrous dysplasia because they gave the term as familial fibrous dysplasia of the jaws. Now, what is the concept? The genetic studies have shown that it is a distinct entity and you should differentiate it from fibrous dysplasia. That is the recent concept. But still, the textbook gives it under familial fibrous dysplasia. That's why we are discussing it here. What is the etiology? Again, like fibrous dysplasia, see, that's why a lot of similarities are there, but it's entirely different. Mutation in the gene encoding SH3BP2. It's a SH3 domain binding protein. This protein has a role in transmitting signals within the cells, especially bone remodeling. So what happens? The mutation in this gene leads to overactivity of this protein. And overactivity of this protein will lead to inflammation of the jaw bones, overproduction of osteoclasts, and destruction of bone tissue during remodeling. So all this will again reflect in the clinical features. Just the simple gene mutation of this will lead to overactivity of this domain binding protein, leading to inflammation of jaw bone, overproduction of osteoclasts. So osteoclastic activity is increasing. So destruction of bone tissue during remodeling. What are the clinical or oral manifestations? Since it exclusively affects the jaw bones, you don't need to write clinical manifestations. You can directly write oral manifestations. Affected children are normal at birth usually. The symptoms will start appearing 1 to 3 years of age. After 1 year of age, bilaterally symmetrical enlargement of the jaws, both maxilla and mandible. Sometimes the enlargement is very rapid, sometimes the enlargement is slow. So when the enlargement increases, the child will resemble a cherub. You know what is a cherub? Angelic face. In the Renaissance paintings, you have certain small kids with, depicted as angels with very chubby face. They are called cherubs. So, under clinical features, I have just segregated it as general facial features and dental abnormalities. What are the general facial features? Cherub face characteristic, that is full moon face, round face, swollen face. Bilateral expansion of maxilla and mandible. The eyes upturned to heaven, that is, eyes will be perpetually turned upwards, upward gaze, the child's eyes. Why? Because there is expansion of the rim of the orbit. So you will have a rim of sclera beneath the iris, forcing the eye to turn up. When you have a scleral rim beneath the iris, your eyes cannot look down. Your eyes will always tend to perpetually turn up. So that is eyes upward, upturned to heaven, upward gaze. Respiratory obstruction. In severe expansion of maxilla, your nose and throat can get compromised. So you will get respiratory obstruction. Impairment of vision and hearing, again in severe expansion of maxilla. And cervical lymphadenopathy. These are all the general facial abnormalities. Dental abnormalities include narrowing of maxillary alveolar ridge, V-shaped palatal arch, missing teeth because the teeth are unable to erupt, crowding in the dental arch and malocclusion, and premature loss of teeth and failure to replace with permanent teeth. So these are the two groups of oral manifestations. General facial features and dental abnormalities. എപ്പോഴും നമ്മൾ ഈ വലിച്ചുവാരി പഠിക്കുന്നതിനേക്കാളും you segregate the features and study, then you will be able to remember. That is always better. See this face? I'm sorry. This is what you find in cherubism, a general expansion of the jaws, enlargement of both maxilla and mandible, bilateral in this particular age group after 1 year. So by 3 to 5 years, it is maximum. So what do you find in the radiography? You find symmetrical bilateral multilocular radiolucencies of maxilla and mandible. Early lesions usually start in the posterior mandible, and then the prominence is then it comes forward to involve the maxilla as well as the rest of the jawbone. You have what is called a hard palate sign. There is a prominence appreciated in the posterior hard palate on the lateral view of the skull. That's what you call hard palate sign. And you also have dental anomalies which are appreciated. Typically, because there is increased osteoclastic activity, you have teeth floating in cystic spaces. That is due to destruction of bone during remodeling. So this is what you think, floating tooth syndrome. You can see multiple teeth, they appear to be floating in cyst-like spaces. And coming to the histopathology, you have a highly cellular connective tissue with many spindle-shaped fibroblasts and multinucleated giant cells. So this is a giant cell lesion. Histopathologic DDs will be all giant cell lesions of histopath, or what you learn in oral pathology, like hyperparathyroidism or brown tumor, aneurysmal bone cyst, central giant cell granuloma, etc. And what are these giant cells? These giant cells represent true osteoclasts because there is a hyperactivity of osteoclasts here. That's why there is bone resorption and plenty of osteoclast giant cells in the histopathology. You will find capillaries lined by endothelial cells surrounded by a thick perivascular cuffing. That's very typical of cherubism. And also areas of hemorrhage. What is the management? The disease is self-limiting. The enlargement slows down when the child reaches 5 years of age. Stops completely by puberty. After puberty, the normal remodeling occurs and the jaw bones come back to normal. And it rarely occurs as part of syndromes like Noonan syndrome, Raman syndrome, and neurofibromatosis. Now, I'm not going to discuss this here, but in the PowerPoint, which I will share with the organizing team, I will include some self-answer questions. In one slide, I have given only the questions. In the other slide, I have given the answers also for that. Now, these are from fibroosseous lesions. Now, in these questions, you should read before going for your Viva, because these are questions which can be asked for Viva. And always keep in mind before the exams, always read from standard textbooks, especially the latest editions. Prepare notes of questions based on previous question papers and draw diagrams whenever needed. When you go for your theory exams, don't forget to keep hematoxin and eosin pencils as well as lead pencils in your box, because only for practicals we take all this for the exam. For theory, we have seen students struggling with diagrams without having these pencils. They just forget. So keep it well in advance in your pencil box. You don't require them for medicine and surgery. You require them only for oral pathology. So thank you. This is my department. Have a safe stay in these COVID times. Take care. Wish you all the best. Thank you.
Thank you, sir, for an enlightening session. It was an honor to have you as one of our resource speakers. And I believe the knowledge you shared with will help our students immensely in their exam. Thank you, sir.
Thank you. Thank you so much.
Our next speaker, Professor Dr. Jubin Thomas, will be speaking on the second segment of this topic, diseases of the bone. Introducing the speaker, Dr. Jubin Thomas is currently the Professor and Head, Department of Oral Pathology, Malabar Dental College and Research Center, and also Director, Nirnaya Orofacial Diagnosis, Muvatupuzha. He has a PG diploma in tobacco control and has publications in various national and international journals. Wholeheartedly, we welcome Professor Dr. Jubin Thomas.
Good morning, Thank you for that wonderful introduction. First of all, I would like to congratulate Team Annoor for coming up with such a beautiful idea. I congratulate the principal, Dr. Jiju, Dr. Deepu, and his entire team in oral pathology in Annoor Dental College. I also thank them for giving me an opportunity to present one of the topics. So without wasting much time, I'm directly getting into the subject. My topic is like bone pathology. Dr. Rakesh sir has already told you about the fibrous lesions. I'll be continuing with the rest of the lesions in bone pathology. By this time, you have noticed that this chapter, the bone pathology, the bone lesions, doesn't contain any lesions that arise due to infections, something like osteomyelitis or neoplasms, the osteoma, osteodosteoma, or the osteosarcoma. Those kind of lesions are not included in this chapter. Then what you see here is a group of generalized disorders or diseases that most commonly affects the maxilla and mandible, and it is described under the term constitutional bone disorders, which means it is there in the constitution, or it is there, it is inherent in the body. Okay, most of the lesions are due to some kind of genetic mutations or some other kind of inherent diseases. One of such inherent disease is osteogenesis imperfecta. This is also known as brittle bone disease. Recently, there was a newspaper article from Kerala. There was a woman who died because of osteogenesis imperfecta. She lived almost till 27 years of age, but during that period, almost 200 plus fractures she had to suffer. She was known as the glass woman of Kerala, and this is an example of brittle bone disease. So brittle bone disease is a divergent group of diseases that is characterized by impairment of collagen maturation. We know that type 1 collagen is present in bone. This is easy to remember like this with B small letter, ONE. When you put a capital letter, it will be much easy to remember always. Type 1 collagen is the bone is a collagen that is present in bone. Not only in bone, it is also present in dentin, sclera, ligaments, and skin. What happens in osteogenesis imperfecta is that a mutation of the structural gene or mutation of the gene, particular gene that decides type 1 collagen maturation undergoes mutation. It results in defect in the biosynthesis of type 1 collagen and maturation. So the fetal collagen is not converted into the mature collagen. So throughout the life, the patient will have immature collagen in the bone, so a weak bone. As I said, it is present in bone. Type 1 collagen is present in bone, which results in fragility of the bone. Then sclera, which appears blue in color. Blue sclera is one of the viva questions which is commonly asked, which is seen in Marfan syndrome also. Then we have dentinogenesis imperfecta or hereditary opalescent dentin. In ligaments, in type 1 collagen, the immature collagen leads to laxity of the ligaments. And we know that there are 3 bones present in the inner ear, the malleus, incus, and stapedius. When there is type 1 collagen defect, the result is hearing loss. There are 4 types of osteogenesis imperfecta: type 1, 2, 3, and 4. Type 1 is autosomal dominant. Type 2, autosomal recessive, but this is the most severe form. Then we have autosomal dominant and autosomal recessive, which is a type 3. And type 4 is again an autosomal dominant type. In the type 1, type 1 osteogenesis imperfecta, this is the patient have a mild to moderate severe bone fragility. This is one of the mildest form. Almost 10% of the cases has fractures at birth. Most fractures that occur during the preschool period, and there is blue sclera present in these type 1 osteogenesis imperfecta, and patient will report to have hearing loss within the first 30 years of life. Dendrogenesis imperfecta, also known as pallescent teeth, it may be present or may not be present. According to that, there are two subtypes, subtype A and subtype B. Subtype A with presence of pallescent teeth, and subtype B with absence of pallescent teeth or dendrogenesis imperfecta. Type 2 osteogenesis imperfecta is the most severe form, which is also known as lethal syndrome. Frequent fractures occur during pregnancy, that means before the birth in utero stage. Almost 100% of the cases will have fractures. Then fractures can occur during delivery. Extreme bone fragility is the cause for death before 4 weeks of age. 90% of the children die before the age of 4 weeks. Then about the dentin, there may be absence of predentin and presence of atubular dentin, or obliteration of the dental tubules will be present. Then dentinogenesis imperfecta is a common feature in this one. And presence of blue sclera is one of the feature of type 2 osteogenesis imperfecta. Moving on to the type 3, this is a moderate to severe bone fragility can be seen in the type 3 osteogenesis imperfecta. Patient will have blue to gray blue sclera, but that usually becomes normal with age. Ligamentous laxity, and almost 1/3 of the cases survive till adulthood, but they die because of the other complications like kyphoscoliosis that leads to cardiopulmonary complications. Kyphosis is nothing but a forward curvature of the spine, and scoliosis is a lateral curvature of the spine. So the patient will have a short stature. Then some patients will have opalescent teeth. When we come to the type 4 osteogenesis imperfecta, which is again mild to moderate bone fragility is seen, sclera is blue, but during the later stages that becomes normal because of the weight that cannot be bared or that cannot be taken by the bones. There is a bowing of the lower limbs, and according to the presence of dendrogenesis imperfecta, there is type A and type B. Now we see the dendrogenesis imperfecta, how it is seen in osteogenesis imperfecta. We have studied about dendrogenesis imperfecta in other chapters. When it is associated with osteogenesis imperfecta, here the primary teeth are most commonly affected. Then there will be enamel wear. The dentin is not supporting the enamel properly, because of which there will be fractures of enamel. There could be the shape of the tooth itself is compromised. It becomes shortened or bell shaped with cervical constriction. As you can see in the first picture, the color of the tooth could be slightly gray, bluish to gray or brown colored teeth are present. Then in the second picture, you can see the obliteration of pulp chamber itself. Histopathologically, we told there is immature collagen, the presence of immature collagen. So you'll be seeing the cortex of the bone itself is spongy. Instead of having a cancellous bone, the cortex is very thin and it is made of a spongy bone. Immature woven bone or immature bone is present throughout life instead of having mature lamellar bone. There could be microfractures due to the inability to withstand forces. So whenever there is cancellous bone present, that is that is fractured. There is no treatment for all these cases, like what we call as constitutional bone disorder. There is no absolute treatment for this kind of lesions, but symptomatic treatments can be done. The patient will have occasional bleeding, internal bleeding, then cardiac malformations, high risk of hypothermia. In case of kyphoscoliosis, intubation is very difficult. There could be fracture of mandible as well as spine. So these are the complications that can happen in osteogenesis imperfecta. Cleidocranial dysplasia, which is the next lesion, which is also known as Mary and Saintons disease. As the name says, cleidocranial dysplasia. There is some abnormality, mostly aplasia or hypoplasia of the cleidum, which is nothing but clavicle, then craniofacial malformation. In addition to that, there are certain supernumerary unerupted teeth are also seen in this lesion. Etiology is again hereditary. The mutation of CBFA1 gene. CBFA1 gene is a normally it guides the osteoblastic differentiation and appropriate bone formation. That doesn't happen in case of a defect in CBFA1 gene. When we come to the clinical features, you'll be finding abnormalities of the skull, teeth and jaw, shoulder girdle, and the long bones, which is usually the growth is restricted. So these 4 points will be considered in the clinical features. So first is clavicle and shoulders, which is the most important feature, the absence, complete or partial absence of the clavicle, which may be affecting the unilateral or bilateral sides, along with the muscles associated with the clavicle are underdeveloped. Neck appears to be long and narrow, and there will be drooping of shoulders. So because of the absence or the partial absence of clavicle. Then because of the unusual mobility of the shoulders, he can bring the shoulders forward until they meet in the midline. Then about the skull. Skull is usually excessively large because of the delayed closure of the sutures and fontanelles. Fontanelles remain open until adulthood. Because of the growth which happens until the adulthood, the shape of the head is brachycephalic. Skull bones, especially the frontal, parietal as well as the occipital bone, gives rise to a large globular shape which is known as Arnold facies. The base of the nose is also broad, but at the same time the nasal bridge is depressed. The mid-facial region, especially the paranasal sinuses, are underdeveloped and they appear narrow. Next is the jaws and teeth. It is nothing but oral manifestation. Because of the mid-facial deficiency, the maxilla is underdeveloped. That gives a high arch palate. Sometimes cleft palate also can be seen. Because of the maxilla is underdeveloped, mandible looks protruded. So when it also leads to prolonged retention of deciduous teeth, which may prevent further develop or further eruption of the permanent teeth. So multiple unerupted supernumerary teeth also can be seen along with the unerupted normal teeth. Then there is absence and deficiency of the cellular cementum. So these are the oral manifestations of cleidocranial dysplasia. No specific treatment has been agreed for cleidocranial dysplasia, especially for the skull, the clavicle, and other bone abnormalities. It cannot be treated in any way. Next important disorder is Paget disease, which is also known as osteitis deformans. As the name says, it results in deformity of the bone. It was first described by Sir James Paget. Usually this lesion is characterized by excessive uncoordinated phases of bone resorption. Then it tries to deposit or the abnormality is being corrected. So which results in a skeletal deformity. Etiology of Paget's disease is unknown, but some kind of chronic, slowly progressive condition is the reason. According to Paget, he thought that it's a chronic inflammatory process that leads to Paget disease. So he called it as osteitis deformans since the lesion appeared as an enlarged bone with tenderness, redness, and warmth. So some kind of inflammation. That's what he thought. Other reasons could be a vascular abnormality or defective connective tissue metabolism, autoimmunity, then some endocrine abnormalities, paramyxoviruses, or it could even be some slow type of viral infection. Pathogenesis is thought to be because of the overreactive osteoclastic destruction that results in a resorption of bone, and the body or the bone tries to respond in such a way that more bone is produced. So, but the forming bone is a haphazard manner, and it happens in different directions. So it results in increase in vascularity to cope up with the demands of new forming bone. So ultimately, the bone what is formed is a very dense and sclerotic bone that has decreased cellularity and vascularity. So that is how the pathogenesis of osteitis deformans is. Commonly, this disorder affects the elderly people more than 50 years of age, and 7 to 10 times it is more commonly seen in the related families. Males are more commonly affected than females, and sometimes it can affect a single bone, where you call it as monostotic, or when it affects multiple bone, it is polyostotic. Symptoms are mainly seen on the bone and nerve tissue. The hematopoietic active flat bones are commonly affected. Sometimes some areas of the long bones are also involved. Then the affected bone becomes enlarged, thickened, and weakened, because of which it has a fracture tendency, which is known as chalkistic fractures. Then, as in case of an inflammation, there is a deep bone pain. Because of the soft base of the skull that leads to descent of cranium onto the cervical spine, it is known as platybasia. Then the long bones or the weight bearing bones, joints especially, show bowing deformity, which is known as simian stance. Simian stance. There will be progressive pain, paresthesia, and gait difficulties. We call it as waddling gait. The neurological symptoms include headache, deafness, blindness, facial paralysis, dizziness, weakness, and mental disturbance. So we thought it is because of the inflammation. It was in case of inflammation, there could be some rise in temperature on the localized area. Yes, here also in the skin, there will be increase in the temperature also can be seen. Maxilla is commonly affected in case of Paget disease than mandible. So when there is an enlargement of the middle third of the face, it leads to a lion-like appearance, which is known as leontiasis osseae. The oral manifestation is very characteristic because of the progressive enlargement of the maxilla. The widening of alveolar ridge happens, and the flattening of palatal vault that results in flattening of the palatal vault. So as the bone size increases, the maxilla size increases, the mobility and spacing of the teeth can develop. Due to the enlargement of the jaw bone, the closure of lip becomes difficult, and that leads to an ever open mouth. The denture wearers always have a problem. They may have to go for larger size dentures always. Other findings include the Paget reported that the complaint of a patient that the skull size is increased so that he has to change the hat regularly. Then hypocementosis that make the extraction difficult because of the excessive vascular stroma. There is bleeding after extraction, and the bone is avascular, because of which after the extraction it goes for severe infection. This is a picture showing a person affected with Paget disease. The maxilla shows an enlargement, anterior portion of the maxilla. The radiographic changes depends on the stage of the lesion, which means in the early stage when there is a bone resorption, there is osteolytic stage, you'll be seeing a radial loosened lesion, as you can see in the skull. It is known as osteoporosis circumscripta. In the second stage, when there is an attempt to heal this radiolucent lesion, there will be a mixed radiolucent radioopacity, which is known as cotton wool appearance because of the patchy opacities. It gives a cotton wool appearance. In a later stage, there is much sclerosis of the bone. It appears clear white in color. In the second picture, you can see the loss of lamina dura and hypercementosis. Bone scintigraphy shows marked uptake of the dye from condyle to condyle, which gives a black beard or Lincoln sign appearance. When we suspect Paget disease, the first thing we do is an X-ray because of the characteristic features. Paget disease can be diagnosed with bone. Then we go for alkaline phosphatase levels. Usually it is increased to a very high level, that is up to 250 Bodansky unit, along with normal calcium phosphate and aminotransferase. This is a characteristic feature of Paget disease. If we check for urine calcium, it is increased as well as hydroxyproline level. Then bone scans can give a very clear idea about the disease, how much the extent and activity of the condition. So these are the diagnostic methods usually. Then we go for histopathologic evaluation. Histologically also, Paget disease has three phases. Initial osteolytic stage, then a subsequent osteoblastic stage, then the sclerotic stage. In the initial osteolytic stage, you can see haphazard arrangement of osteoclast, which results in bone resorption. Osteoclast has multiple nucleus, you can see in this picture. In the second stage, when there is bone formation, you will be able to see the reversal lines. The osteoclastic activity is being replaced by osteoblastic activity, which results in a mosaic pattern or tile arrangement, and ultimately it leads to jigsaw puzzle arrangement. In the sclerotic phase, there is a decrease in the osteoclastic activity and complete osteoblastic function happens, which results in a thickened bone which has no structural integrity. As you can see in this picture, there is sclerotic bone. There is no specific treatment for Paget disease, but symptomatic treatments have been tried. Analgesics have been administered for pain. Then calcitonin, which is a parathormone antagonist, which suppresses the bone resorptive activity and helps in bone deposition. Then cytotoxic drugs like bisphosphonates, nitramycin, all those things have been tried. There are certain complications also can result. There are pathologic fractures. Sometimes sarcomatous changes have been reported in pagetic bone. Then other comorbidities like serious abnormalities have also been reported in case of Paget disease. Now we have two syndromes to cover. When a group of symptoms which consistently occur together, you can call it as a syndrome. Okay, here we have one important syndrome is Down syndrome, and the other one is Marfan syndrome. Down syndrome is also known as trisomy 21 or Mongolism. Down syndrome is the most common autosomal abnormality. It is characterized by subnormal mentality with a wide varieties of anomalies and functional disorders. Two of them are associated with the cranial as well as facial deformities. 1 out of 700 live birth is expected to have Down syndrome. That common it is. The etiology of Down syndrome, we called it as trisomy 21, which means 95% of the Down syndrome cases has an extra chromosome. That means a 47 chromosome is present in 95% of the cases. 3% of the cases has chromosomal translocation and chromosomal mosaicism, which means abnormal number or abnormal location of the chromosome in the same individual can be seen. That is mosaicism, which can be which also contributes to 2% of Down syndrome. The clinical features and oral manifestations of Down syndrome are very common Viva questions. Mental retardation is the most common feature that can be noted in a person with Down syndrome. The patient will have a small head. The height of the head is usually small with a brachiocephaly. Brachiocephaly means it's a wide face as well as with a flat back portion of the head. Brachiocephaly. Then hypertelorism, when the eyes are located wide apart, it is called as hypertelorism. The patient will have a broad, short neck. Height will be less, a short stature. Large fontanelles will be present, but the sinuses, especially the frontal sinus as well as the sphenoid sinuses, are hypoplastic or it may be absent. You can see the flat facial profile in this picture as well as flat occiput, which is the brachiocephaly, which is brachiocephaly. Then you can see epicanthic fold. Epicanthic fold is nothing but a fold of upper eyelid that can be seen onto the inner corner of the eye. Then the eyes are slightly slanted towards the upward slanting. Then flat nasal bridge. Tongue is most of the time protruding. These are the common features that can be noted in a Down syndrome patient. When we come to the oral manifestation, we can see macroglossia. Maybe that could be a reason for the open mouth, which results in difficulty in eating as well as sleeping. The patient will have a scrotal tongue, hyperplasia of the maxilla, which appears like a protruded mandible because of the hyperplastic maxilla. Also, delayed tooth eruption as well as supernumerary teeth are one of the feature. Partial anodontia, enamel hyperplasia, juvenile periodontitis, cleft lip or palate are the features of oral manifestations of Down syndrome. Then what you can see is a fissuring of lips as well as angular cheilitis. Okay. Next we have Marfan syndrome. This is again a disorder affecting the connective tissue. Basically, it's a heritable disorder of connective tissue, which is characterized by abnormalities of the skeletal, cardiac, and ocular systems. A defective organization of the collagen is the reason for Marfan syndrome. It has skeletal deformities, cardiac deformities, and ocular deformities. About the skeletal deformity, the patient will have tall, slender stature with relatively long legs and arms. Usually, they are disproportionately long in relation to the trunk size. Then the hands are very large with large, long fingers, loose joints. So this is what the skeletal deformity. And about the CVS system or cardiac system, patient will have a mitral valve prolapse, aortic regurgitation, and heart failure. Then when we move to the ocular findings, we have already mentioned about blue sclera in Marfan syndrome when we studied the previous lesions. Then discoloration of the lens and myopia. So blue sclera myopia and discoloration of the lens are the eye symptoms. The patient has a long face, because of it he will have high arch palate. When there is high arch palate, there is a tendency to collapse of the arch, which leads to crowding, that is malocclusion crowding. Then bifidobula, sometimes TMJ dislocations. So these are the oral manifestations of Marfan syndrome. Then we have achondroplasia, a disturbance in the cartilage formation. Basically, achondroplasia is a disturbance in the endochondral bone formation, which results in dwarfism. It's a hereditary condition with autosomal dominant inheritance. Clinical features: the patients are usually dwarfs. They have thick muscular extremities. Then skull is usually brachycephalic with broad legs. The hands are usually small. Fingers are stubby compared to the long trunk. Then the second picture, you can see they have a curvature of the spine inward. The back of the body, you can see that, which is known as lumbar lordosis. Then they have prominent buttocks, protruding abdomen. So these are the features of achondroplasia. And about the hands, there is ulnar deviation which produces this playing of the fingers, which is known as trident hands. When we come to the facial and skull features, the patient usually has a large skull with short base. The base of the skull growth is restricted, because of which the maxillary retrusion can be seen. Ultimately, the patient will look like slightly prognathic because of the short maxilla. So these are the features of achondroplasia. Langerhans histiocytosis. This is also known as histiocytosis X. It is considered as a part of a spectrum of diseases or disorders that is due to proliferation of histiocyte-like cells, which also show the presence of some other inflammatory cells like eosinophils, lymphocytes, plasma cells, and multinucleated giant cells. The histiocytes here in this lesion is known as Langerhans cells. You know what's a Langerhans cell, right? Langerhans cells are antigen presenting cells, which we have studied in our oral mucosa. They are also present in epidermis and bone marrow. About the etiopathogenesis, this is the most important part of Langerhans cell histiocytosis, whether it is due to a neoplastic process. The histiocytic proliferation is due to a neoplastic process or a non-neoplastic condition is still in debate. But studies have shown that all the Langerhans cell has a single mother cell or a monoclonal origin, which leads to a point that this could be arising from a neoplastic process. We discussed it is a part of a spectrum of disorders. When it affects a single bone or a solitary or a multiple bone without visceral involvement, we can call it as monostotic or polystotic eosinophilic granuloma. When it is involving bone, sclera, and bone, skin, and viscera, you can call it as chronic disseminated histiocytosis or hand shell acquisition disease. And there is a third variant, disease involving skin, viscera, and bone marrow in the infants. You can call it as acute disseminated histiocytosis or Letterer CV disease. So we are not expecting an essay from this portion of the bone lesion, but short essays have been asked about cleidocranial dysplasia, Down syndrome. So in cleidocranial dysplasia, you should mention about the skull, brachycephalic skull. Then the clavicle can be approximated anterior to the chest. Those kind of things has to be included. Down syndrome is being asked. Then you'll get more of viva questions. Paget disease is one of the favorite portions for almost all the examiners, about the alkaline phosphatase, then the histology, cotton wool appearance. Those kind of things can be asked. Then sometimes you get a question from the Marfan syndrome in viva. Down syndrome, it is a very common question in Down syndrome. Then blue sclera, wherever it is present, like osteogenesis imperfecta as well as in Marfan syndrome. These are the common questions that can be expected in examination. And that's it. That's about the bone lesions. Thank you so much. Thank you so much.
Thank you, sir. Thank you, sir. That was diseases of bone in a nutshell. Moving on, may I now invite Dr. Deepu George Matthew, head of the department, Annoor Dental College and Hospital, to summarize today's session.
And then, good morning to, good afternoon to all of you, all the participants here. I'm very thankful that like there have been a very overwhelming response for this program that we have been conducting. And I think more YouTube views are coming for the videos that has been, the presentations that has been done. I think the previous week's presentation has already got some 600 to 700 views have already come. I'm very happy that the students are utilizing this opportunity and they are learning a lot about the orthopathology part. Now coming to, I'm just here to thank mainly the speakers who had taken their time from their busy schedule to come here and help us out and give their inputs about the exam topics, especially Dr. Sudha ma'am, Dr. Rakesh sir, and Dr. Jubin. I'd like to extend my thanks for all of them. And Dr. Priya, our own faculty, she has done an excellent job today. Now, the reason why I have come today is to give a summary of the whole program that has been conducted today. See, today we have discussed mainly from three parts of the orthopathology. That is the epithelial pathology, salivary gland tumors or salivary gland diseases, and we have dealt about the bone pathology. Now, these are the three main areas from where the questions can come for your university exams. Okay, so here we have to see that epithelial pathology is one of the most important part, but what Dr. Sudha ma'am has dealt with. And especially for KUHS exams, the Kerala University of Health Sciences exams, you'll see that mainly three essay questions usually is being asked from this particular part. The three main diseases that is being usually asked as essays is, one is leukoplakia, the second one is squamous cell carcinoma, and the third one is oral submucous fibrosis. So without learning these three things, don't go for exams. It's very, very important. And usually the essays are asked, especially for leukoplakia, they will ask define pre-malignant lesions, conditions with examples, and then discuss in detail the etiology, pathogenesis, clinical features, and histopathology of leukoplakia. If a question like that is being asked, madam has already discussed in detail. I'm just giving you a nutshell things so that as a take-home message, when you go back, these are the things that should be there in your head, when you're going back, after the session. So when you talk about, you have to remember and by heart the definition of pre-malignant lesion, condition, and nowadays potentially malignant disorders are also included. So you put all this pre-malignant lesion and conditions together, what you get is potentially malignant disorder. Okay, so you need to know the definitions of all these three components. Then you have to know the examples for each of them. Don't confuse between each other and don't change the examples between the pre-malignant lesions and conditions. Then you have to remember the definition of leukoplakia. That's very, very important. So when you, as we have told the previous sessions, you have to write the contents when you are started to write the essays for leukoplakia. So you have to start with the definition of pre-malignant lesion, definition of pre-malignant condition, then examples for each. Then you have to write the definition of leukoplakia should be the next part of the heading. Then an introduction should be given for leukoplakia. Then you have to talk about the etiology. Under etiology will come the chemical, biological, and physical. The same like squamous cell carcinoma, because it's just a beginning of or like the stage before squamous cell carcinoma. So under chemical, tobacco will come, smoking tobacco, smokeless tobacco, nitrosamines will come. Then under physical, like you have UV radiations, or like you have like trauma. And under biological, you have viral, bacterial, and fungal. So Candida albicans is implicated. Like an HPV virus is implicated from viral part. From bacteria, Treponema pallidum is being implicated. Then you come to the clinical part. You have to write about the clinical types of leukoplakia. So broadly, we can divide them into homogeneous and non-homogeneous leukoplakias. Under homogeneous leukoplakia, you have thin smooth leukoplakia, thick fissured leukoplakia, verrucous leukoplakia, and granular leukoplakia. Then you come to non-homogeneous leukoplakias. You have spectral leukoplakia, where like you have leukoerythroplakias, erythroleukoplakias. Then you come to histopathology, where you have the dysplastic features. Under dysplastic features, you have the architectural features and the cytological features. Then you come to the treatment part, and then you have to talk about the grading of dysplasia. Then you come to the treatment part. Then you come to the prognosis. Okay, so these are the headings under which you have to write an essay if something is asked about leukoplakia. Then it comes to submucous fibrosis. Again, the same first part will be there. Usually asked for the submucous fibrosis, the premalignant lesion, define premalignant lesions and conditions with examples, and discuss in detail like the clinical histopathology of submucous fibrosis. There also you have to start like this. But again, you remember you have to know the definition of oral submucous fibrosis, then the etiology and the pathogenesis. So etiology, mainly aracanid chewing. Okay, and the aracholine and aracholine, arachidine, guacoline, all those alkaloids which induces fibrosis. Then you can put a flow chart about like how the fibrosis is occurring. You can talk about like there is a decrease in the collagen degradation and increase in the collagen production. So a flow chart you can put for that. Then you talk about the clinical features, initial phases and advanced phases. Then you talk about the staging of the oral submucous, clinical staging of oral submucous fibrosis. Then you go to histopathology, then the histopathology grading, then treatment and prognosis, or whatever is the malignant transformation rate. Then comes the squamous cell carcinomas. Okay, definitely squamous cell carcinomas. Usually they will ask, start the question in squamous cell carcinoma as classify the or enumerate the various non-odontogenic epithelial tumors. So if a question like a classification is asked like that, you have to just make up a classification where in which, so it's about non-odontogenic epithelial tumors. So mainly the tumors that is arising from the surface epithelium, that is the all these benign tumors like squamous papillomas, verruca vulgaris and all. And the malignant ones will be squamous cell carcinomas, verrucous carcinoma, and basal cell carcinoma. Then the other category will be salivary gland tumors, because it's asked as non-odontogenic epithelial tumors. Benign salivary gland tumors and malignant salivary gland tumors, as Dr. Priya has already mentioned. Then you talk about and give an introduction for the squamous cell carcinoma, the etiology for squamous cell carcinoma, same like what you have discussed in your leukoplakia. Then the pathogenesis, that is a sequential accumulation of genetic mutations, and slowly like it is transforming into a malignancy. Then you talk about the clinical features, the endophytic, exophytic, ulcerative, all those kind of clinical appearances the squamous cell carcinomas can take. Then the clinical staging of squamous cell carcinoma, the TNM staging. Then you discuss about the histopathology. Then you discuss about the grading, WHO grading of squamous cell carcinoma, well differentiated, moderately, and poorly differentiated. Remember, you have to draw diagrams, histologic diagrams. If it's a squamous cell carcinoma, draw a diagram of a well differentiated squamous cell carcinoma with a lot of keratin pearl formation. If it is a submucous fibrosis, draw a diagram with a lot of fibrosis and an atrophic epithelium. If it is a leukoplakia, show a histopathology diagram with a bulbous retroids with a lot of dysplastic features, very prominent nuclei, and like increased nuclear cytoplasmic ratio. Make a diagram like that. But make sure like you keep on drawing, and you have to keep on practicing before exams, so that you should be able to draw this diagram within a span of 1 minute. If you go beyond that, if you take 5 minutes for drawing that, you will not be able to finish your essay in time. I told you like your essay has to finish within 25 to 30 minutes. So you have to practice drawing these diagrams. A decent diagram, don't have to be something like a Michelangelo's art piece or something like that. You just have to have a decent diagram and label the parts. That's more than enough. Now that's about the epithelial pathology. When it comes to the bone lesions, remember the main important essay question that has been always been asked is classify fibrosis lesions and discuss in detail fibrous dysplasia. It's the most common question that has been asked, and rarely they have asked about Page's disease. So it's very important. Dr. Rakesh sir has elaborately discussed about the various lesions that has been discussed, the lesions that comes under the fibrosis diseases. So you have to give more that emphasis on that fibrous dysplasia, because that's the main essay question that has been asked, the classification. So sir has discussed about two types of classifications. One is a Waldron's classification. The other one was a working classification, where like hereditary disease like cherubism is also added into it. And along with that, the other short notes, like what Dr. Jubin has already discussed, like cleidocranial dysplasia, achondroplasia, Page's disease, and Marfan syndrome. All those kind of questions can be also asked as a 5-mark question, or even as a 3-mark question. Depending upon the marks that has been given, you have to elaborate or you have to shorten up so that you don't waste enough lot of time for each questions. Now comes the salivary gland tumors, very important. Okay. And Dr. Priya has given an excellent talk on salivary gland tumors. So the main important thing is the classification you have to remember about the salivary gland tumors. You just have to divide them into benign lesions and the malignant lesions. And it's very easy for you to do that. Usually the most common question is classify salivary gland tumors and discuss in detail the clinical and the histopathology and histopathology features of pleomorphic adenoma. That's the most common question that is being asked. So you have to remember that, you have to learn that before going for your exams. Now, when you write an essay for a salivary gland tumor, the scheme has to be first the classification, if that has been asked. Then you talk about, give a small introduction to the tumor. So I have already discussed in the previous session that when you give an introduction, you can just talk about what is the disease basically, what is the main pathologic process that is happening, and which is the site that is being commonly involved. So those kind of small things you can just put 3-4 points. The introduction is more than enough. Now, another important part that is there in salivary gland disease is histogenesis. So all these tumors have got different types of histogenesis, different types of cells that has been involved. So histogenesis is another important part of salivary gland tumor. Then you talk about the clinical features. Then you come to the histopathology, then treatment and prognosis. So that is a scheme that you have to follow. Again, you have to start learning how to draw these diagrams and without wasting much time. So other than pleomorphic adenoma, the next probable questions are mucoepidermoid carcinoma and adenoid cystic carcinoma and Warthin's tumor. So this much, if you learn, you almost covered the whole of salivary gland tumors. I'm not telling you that, these are the only questions that can come. Around 70 to 80% of the questions will be within this, for an undergraduate level, it will be within this particular range. It's going to come. So I hope, we are able to do justice for you and give you a lot of inputs regarding the exams that is going to come within a few months' time. So that's all from our part. So thank you so much for your patient listening and being with us throughout the day. Thank you so much. Over to you, Dr. Brianna.
Thank you, sir. Thank you very much. Now that we have come to the end of today's session, that is the sessions for day 2 in the Exam Tips 2021. Our platform was blessed and enriched with such eminent laurels in faculty for the day, being the faculty for the day. Hope all the students have been, this was a very useful session for all the students. Now, on behalf of Annoor Dental College and Hospital, may I thank our esteemed faculty members for their comprehensive and informative sessions today. Thank you, sirs and ma'ams. Before we wind up, a gentle reminder regarding the day 3 sessions of Exam Tips 2021, scheduled on September 19th. We will be having Professor Dr. Sunil S., Head of the Department, Pushpagiri College of Dental Sciences, with the topic Odontogenic Cysts. Odontogenic tumors, another topic, will be dealt by Dr. Anthony, Head of the Department, MAS Dental College, and Professor Dr. Deepu George Matthew, Head of the Department, Annoor Dental College. Next, another topic will be connective tissue tumors by Dr. Lakshmi Priya from Nirnaya Diagnostics. Looking forward to meet you all in the next sessions. A word of gratitude for all students who have participated patiently in this today's session. And thank you and have a nice week ahead. Stay safe and stay healthy. Thank you.